Please start in 3, 2, 1. Please start, sir. We are live.
So hello, good evening, and sorry, all yours, Dr. Sahu.
Yeah, please start, Tarun. Sorry. Please.
So very good evening and namaskar, and it's a great pleasure to welcome you all for this Breast Cancer Deep Dive 2024. It's a pleasure to welcome and invite the program convener, Dr. T.P. Sahu, sir. I think everyone knows Dr. Sahu, a senior consultant medical oncologist at Bhopal. Now I give the floor to Dr. Sahu for the welcome introduction and setting up contacts for today's discussion. Dr. Sahu, sir, over to you, please.
Yeah, thank you, Tarun, and thank you, actually, everyone who has joined in on a working day in the evening. The concept goes, it is along with this, it's actually a sister program to what Dr. Vamsi did for the GI. And what we wanted to intend to do is at least discuss only abstracts that has been relevant to practice in the last 6 to 8 months. Point number one. Second, what we wanted to do is no dialectical lectures, nothing as a lecture, except for probably one which we'll be having tomorrow on statistics, which will interest all of us. And they will have panel discussions, and I'll ask all the moderators to, if they can spare the last 5 minutes of the discussion to the chat box, and we can address them, and we can also involve the participants who are not faculties. And I see an impressive 80-90 people already in, and most likely 300 registered. We can, if we cross 100, and students would be majority of them. So really, we can really help in the academic and this academic endeavor. So without delaying much, I start off with the first session, and the first day will be dedicated to early breast cancer, and the second day will be metastatic breast cancer. And the last program of day one, before Dr. Parikh gives the expert opinion, we'll be looking into the crystal ball and thinking what we will be doing in breast cancer in 2028. That will be by Dr. Amol. So first one, Dr. Vamsi, he is a renowned medical oncologist and a dear friend, colleague from Hyderabad. And he will be doing on the hormone positive breast cancer. Vamsi, all yours.
Thank you, Dr. Sahu. Thank you so much for having me here. It's a great pleasure to start this interesting breast cancer deep dive. I have Dr. Chetan Deshmukh, I have Dr. Amish Vora, and I have Dr. Soumya Panda all there with me. As Dr. Sahu said, the idea of this meeting is that we're going to try and look at certain abstracts presented in ASCO in some depth and try to see how, if at all, it will change our practice. One request to the technical team, please let me know when there are 5 minutes left. I'm not able to see the timer here. So just let me know when 5 minutes are left. Next slide, please. So today we will be discussing about hormone receptor positive EBC. And as anyone who has been reading about EBC, I really don't know what is EBC anymore. I don't know if this should be kept as a group separately, because we have node positive, node negative. Everything is being clubbed under EBC today. So, you know, this EBC itself is a bit different. Next slide. So first off, let's talk about two drugs which have really completely changed our understanding and our discussion about HR positive EBC in the last couple of years. This graph, which is on the top right, top left, shows you the abemaciclib data. This is the final overall survival curves cross. The difference between the two arms, that is abema plus hormone versus only hormone, is around 13 months. It is not statistically significant as per the pre-specified p-value. The second graph shows you the ribociclib arm, wherein there's a difference of 3%, which is showing an IDFS significance. Next slide. So I'll jump straight to this year's ASCO group, which looked at the baseline characteristics and efficacy endpoints for patients with node negative, HR positive, HER2 negative breast cancer. Next slide. Now, just to refresh everyone, the Natalie study included two groups of patients. You had node positive and you had node negative. Now, node negative included anybody who had a grade 3 disease or a grade 2 with evidence of high risk, which was identified as a Ki67 more than 27%, or an Oncotype DX breast recurrence score of more than 26, or a high risk with other diseases, other genomic profile. Essentially, this included stage 2A N0 disease. All patients with T2B, that is T3N0 or T4N0, were automatically also included. So remember, N0 includes T2, T3, TB. T2 needed other high-risk factors. Next slide. Now, this is the baseline characteristics. And now look at the numbers. Your total number of patients who were having this node negative are around 285 and 328 in both arms. They're not small numbers. 2A is 74%. Grade 2 is around 33% with Ki67 more than 20. Ki67 with high genomic risk is only 3%. And the other unknown genomic is 13%. Grade 3 is 46% of these patients. So jumping straight in, Dr. Amish, Natalie, we have discussed thoroughly. What is your thought? Was it an overambitious trial trying to put in place these node negative with such so-called high-risk features? Is this a biological group that is significant? Dr. Amish.
So I think, I personally think that till we reach 100% cure rate, I think there is always a scope of improvement. My only issue was with such a large number of, they included 5,000 patients plus patients, so that the difference in the statistics, even small difference, can have a bigger hazard ratio or a significant hazard ratio. In addition to that, now deep diving into node negative and these things, this is ambitious. I will not call it over ambitious. I think till the time we can save even one recurrence, it's worth looking at these aspects. This would be my thought process.
Okay. Dr. Chetan, Dr. Amish said 5,000 patients, but your node negative subgroup is 613. And now you are kind of breaking it down, trying to find these small differences with 600 patients. And you have such a broad group. You know, you're saying Ki67 more than 20%, Ki67 less than 20, high genomic risk, any grade 3. A node negative group of population. It's not a small population. So, Dr. Chetan, your take on these inclusion criteria?
So I think the node negative subgroup has probably diluted the whole thing. The issues are, there are two, the so-called high-risk features which they have used. One is Ki67 more than 20%, which we know that requires a lot of standardization, and there can be heterogeneous Ki67 reports from all places. The second thing is about genomic high-risk genomic score. So more than 26. This is just my thought. Okay, I don't say that there is data to say that, but somebody who has a genomic score of 30 versus 40 versus 50, I'm sure the risk probably changes a lot according to that. They've clubbed everybody, all high-risk genomic scores at one go. And it's a sizable number. It's almost 10% of the study population. So, I don't know. I personally feel that they should have kept it purely node positive patients. It would have made it a little easier.
Perfect. I think that's where the discussion went, because, you know, from the day the trial was announced, we're all curious as to what is happening in this node negative sub. You know, typically a node negative is where we would be a bit more relaxed, a HR positive, because remember, they have not used certain other characteristics. Because in clinical practice, an aged elderly patient will still fulfill this criteria. Are you going to subject them for a long course of CDK? That's the thought. Soumya, if I can ask you a more different question. In our clinical practice, does this really matter? You know, we keep seeing larger tumors. We keep saying patients in India are younger, they have bigger tumors. Is that true anymore? Are we really having this group as a significant population in our clinical practice?
So for us, it is the numbers are really less. Only thing is that the Natalie trial that had included 5,000 patients. So the 600 patients, it comes to around 12%.
10%.
I thought that a non-negative initially they had declared it something more than 20%. But they have not declared all the population, so it is only 12%. So there is some.
They did not actually stratify and say we needed X number of patients. I think that's one thing which possibly would have helped them more. I mean, that's something that could have been done. They did not specify that we wanted at least 25% patients who were node negative. You know, that would have made a difference, is what you are saying. Perfect. I agree with you on that. Dr. Amish, you are practicing in a slightly different area, Hoskas, Delhi. So would you say this number is insignificant? This number of, you know, the patients will be covered under this node negative subgroup who require ribocycling?
I didn't understand the question.
My question to you is, how common is this subgroup in your clinical practice? Would you say it's 10% of your patients, 5% of your patients, 20% of your patients?
No, definitely 10% of the patients, Vamshi, because nowadays the place where I practice, more and more women are able to identify earlier and earlier tumors. So I personally think is that it will be definitely more than 10%. 10% or above.
Perfect. Perfect. Dr. Chetan, your take on this. The reason I'm asking is this just a storm in a teacup? Are we just debating something that has no implication in India? Or is it something that matters to Indians as well? Dr. Chetan.
I think in my practice, it is a little more than that. It is probably anywhere between 15 to 20%.
Perfect. So I agree with you on this because this is what we are facing. This is not a number that we typically look at. I don't think till 1 or 2 years back, if I had seen a node negative, I would just go ahead and say, fine, let's do a genomic assessment and then decide on chemo. The whole idea of whether we should look at the Ki67, we should look at the number of nodes, whether it's this, it's something that is different for all of us. So I think that's where the challenge comes. Next slide. Okay, next slide, please. Dr. Amish, back to you. Look at this IDFS. I mean, I know it's 600 patients with 250, 250. You have a 0.73 hazard ratio, 0.4 to 1.38. Then you have the other side, a DDFS and DRFS. Now, DRFS and DDFS, they say correlates more to OS, even better. Look at the hazard ratio. It's all over the place, 0.3 to 1.3. How significant is this for you?
So I think the whole Natali results right now is debatable. It's not only this particular subset which is debatable. I think important point here is how I look at all these things is the control arm. If you see the T2N0, T3N0 control arm still is at 91 and 92%.
Perfect.
So
yes.
We still have 9% and 8% of the recurrences to prevent. Now, whether 3 years of ribociclib prevents this, I have a further problem with this chart also, Vamshi. If you look at the censoring of the events in the first 6 months, there is a lot of criticism going about that.
Correct.
And if you remove that and if you do, these hazard ratio further become 0.85 and 0.9. So it is very difficult, but going by the graph which you have shown in front of me, the entire group is definitely little debatable because it is crossing the line of unity. But the DRFS, the hazard ratio of 0.58, even though it is just touching the line of unity, looks little better because the 3-year rate, the difference is around 3.5 to 4%. But again, not very convincing slide.
Perfect. I agree. This is what I wanted from you. Dr. Amol has been asking and keeping on asking about the Oncotype DX. I'll come to Oncotype DX in 5 minutes, Dr. Amol. Right? Dr. Sahu has also said that the group is significant. It is 20 to 30%, and that 20 to 30% of patients do relapse at the end of 10 years. So that is why the whole reason what Amish is saying as well, that yes, it's a subset where you would want 100% survival. You do not want this 80, 90% survival. Point completely taken. Right. Next slide, please. So this is what, again, now we come to the ASCO guidelines. And again, I'm not very happy about this guideline because it takes a very easy way out. It says recommendation 1, wherever you fulfill abemaciclib, give it. It's got high strength of recommendation. And there's a ribociclib which says give it wherever it has been used with a conditional response. Would you agree with this for the conditional recommendation? Dr. Soumya, your thought on this?
They have told clearly that it is the email for the Natali to come in. So right now the data is very premature for the Natali. The failure, if you look at the events, it is only less than 20. So 17 events, 15 events in the NGO subset. So mostly they have given a lot of caution that abemaciclib, yes, but for ribociclib, it is right now too preliminary. And they are told that only in a selective, very high risk, and we don't know which one is the highest risk in that particular subset, in the N0 subset. So mostly the data is favoring towards abemaciclib rather than the ribociclib in this particular paper.
Okay. So you also, Dr. Amish, your take. I remember in one meeting you said, look, I am not at all happy with these recommendations. You have issues with this recommendation.
Yeah, because, sorry, you said they have taken an easy way out. You know,
Yes,
I think
this looks like an easy way out because they're given
that is
approval for
not
both.
expected from ESCO. Basically, you know, we look at that. The second recommendation to, if you remove the conditional, I think it is okay. The important point, I think, you know, we discussed once when we were discussing monarchy in detail, Vamshi, that today, if we have a 3% at 3 years or 4% at 3 years, and the way abemaciclib has shown, the survival graph has widened over 3 years, 4 years, and 5 years. You really don't know. In a metastatic setting, if we look at it, ribociclib is the only CDK4/6 which has consistently shown OS advantage. So we'll have to wait for 5 years. But the idea is what they are recommending and what I agree, Vamshi, that today if I have a T2N0 patient with grade 3 with Ki67 of 30%, do I want to wait for 2 more years before the data matures, or can I offer ribociclib? And this recommendation too at least gives me strength enough to discuss, and the Natalie gives me strength enough to discuss with the patient.
Perfect. I think that's a very good take home, that you will discuss this with the patient, right? I think that's the key for me. Okay, next slide. So let's just have one case. This is a real case which came to me yesterday. So we had been treating this patient for a while. It's a 72-year-old lady with a biopsy. Now, grade 3, ER 5/8, so low ER relatively, 6/8 PR, HER2 negative, Ki67 20%, bang on there. Patient underwent a surgery, IDC 2.3 centimeters, so T2. Now, this is node positive, 2/16, but 72-year-old lady with some comorbids. So I think everyone will say, let's just do a oncotype DX. Next slide. This patient, we offered oncotype, but patient then went ahead and did a CAN assist. This was offered by somebody else. Now, this is the score. It is a high risk on CAN assist. Before Amol points out, yes, the data on node positive CAN assist is not yet out. The data is apparently coming out, is what I've been told. Now, this patient, after second cycle of TC, developed febrile neutropenia grade 4. So obviously, we had to stop all the chemotherapy. So now, Soumya, this patient is there, T2N0, but grade 3, and patient is going to come with a Ki67 of 20%. Would you offer a ribociclib for this patient?
But Vamshi, you have said 2 lymph nodes are positive.
I'm coming to that, Dr. Amish. I'm coming to that. This patient qualifies for abema as well because she's grade 3. So would you offer ribo also? If supposing this was node negative, let's take it at that point. If it was node negative, would you offer ribociclib? Just based on this CAN assist report and the high key index with a grade 3.
No, I won't be offering ribociclib.
You would not be offering ribociclib. Okay. Dr. Chetan. Dr. Chetan, would you offer ribociclib if this was a node
I got
negative?
your question. So the point is, the chemotherapy which has been given is less than adequate.
Correct.
So are we substituting the less than adequate chemotherapy with a CDK4/6 inhibitor? Is what we are doing it. We are doing it that way. So
okay. So would you offer?
So if at all I have to offer it, assuming that she is node positive as such, the patient is node positive, 2 nodes positive, and all the other scenario you mentioned, I would offer abemaciclib.
Okay, perfect. I agree with you on that. But supposing this was node negative with a CAN assist high risk, would you offer it?
I would still, based on your grade 3 and with comorbidities, where again I'm going to play it safe that my chemotherapy will not be able to. I won't be able to give all the chemotherapy required. Then I would probably offer abemaciclib.
Okay. So, Dr. Amish, 5 years back, if this patient came into your OPD, and I'm telling you, this is with all senior all of us, 72-year-old, comorbids, ERPR positive, you would just say, listen, nothing doing T2N0, sit at, just take a hormone tablet and be happy. Forget chemotherapy. This was the criticism against molecular test. And today we are saying, okay, give chemo, give a second drug for 3 years. Dr. Amish, I mean, there's a huge paradigm change in the last 5 years.
I would offer ribociclib to this patient, even if this patient would have finished all the 4 cycles of TC also, contrary to what Dr. Chetan said. If it is node negative, there are 2 high-risk features. One is grade 3, and the second is CAN assist higher score, and the cutoff is 15.5. It is a significantly high score if you want to believe in CAN assist. Okay. And the third important point is, Vamshi, you thought this patient is fit for TC. So I'm sure this patient is fit for CDK4/6 also.
Very good.
So
Agreed.
I would
But-
definitely offer.
Okay, very good. No, why I'm saying is there was a lot of discussion as usual. Patient did go around and there were people who said, don't give any chemo, don't do your 72, you just sit and, take a hormone tablet. That was the advice also given to us. So that seems to be a still prevailing notion. I won't say it's a standard notion, but some people do have that. So I think we should disabuse of that. Look at other features, and all of us are talking about that subset which does bad. Very good. So
Sorry,
next slide.
Vamshi,
Yes.
Vamshi, and Natalie trial, 76 and 78% of patients had taken chemo. That means the remaining 22-24% did not take chemo and they still received ribociclib.
Fair enough. I agree with that point. So that is what Amol was asking, which I was about to say that, okay, we cannot say that you're substituting chemo with ribo. It's a different drug, probably acting in a different test. Next slide, please. Right. So this is where the approvals are there for both of them. I just put it on one slide. Next slide. Let me now go to a different thing. Next slide. Next slide. Next slide. Right. Risk predictors. Dr. Amish, we have a can assist, which node positive we don't have. Can assist was not included in Natalie. You're comfortable, however, saying that it represents a similar population. Amol has been asking that because oncotype has not been validated in Indian population. Can assist has been in a node negative setup. So are you okay? Because remember, the Natalie included PAM50, it included EndoPredict, it included oncotype. So are you comfortable in interchanging all of these things?
See, G3, Ki67 and high risk genomic profile. If I have a can assist and if it fulfills one more other criteria also, Vamshi, I would be comfortable accepting can assist. But if I have grade 1, grade 2, if I have Ki67 of 8 to 10%, and then I have a can assist of 14 score, I may not accept that for the use of CDK4/6 inhibitor.
So Dr. Soumya, same question to you. Would you accept all of these as similar to each other? So anyone high risk becomes a high risk, or are you going to stick to the trial and say, okay, only these were included, I will use only these? What is your take on this?
I stick to the trial criteria. I don't use the can assist as of now.
You would use or not use?
No, I will stick to the trial criteria.
You would use it as per trial. Okay. Dr. Chetan? Dr. Chetan?
Sorry, I didn't get Dr. Soumya's answer and your question.
Okay, the question is, are you okay to use any of the molecular tests interchangeably? So anything says high risk, you're okay with saying, yes, it is high risk, I will use a CDK inhibitor? Or are you going to stick to Natalie and say they used oncotype, so I will use oncotype only? Or they use PAM50, I use only that? That's my question.
No, I would use any of the genetic markers based on the risk. Whatever risk they offer, I would take it at face value and offer it.
Perfect. Okay, great. So this is something which is controversial. We are not going to have an answer. Dr. Amol has been messaging saying that no, he will not accept. He will stick to trial. But I think on a more liberal, practical view, a lot of us might accept this. This was an interesting paper which actually came from the Cancer Institute Adyar, which showed a risk predictor of PAM50 from India. Next slide. They actually looked at luminal A, luminal B, and looked at the recurrence score and found that the recurrence score was very high for luminal B. So this is what they found, that RORC was higher in the luminal B. Next slide. And interestingly, this correlated with something called the breast cancer proliferation score, so the BCP score. And in the study, it showed that 75% who were having high luminal B were actually luminal B. So most of them were luminal B. So again, interesting that there is some data from India on the PAM50. Next slide. Next slide. Next slide. So this brings me to the other question. So this patient, now remember this was, we have discussed this. Next slide. The reason why I put this is because there was a paper which I did not discuss today on the AI modeling of high risk scoring. And the AI also gives you a model which tells you which is high score. There is a DigiStain which is going to tell you which is high score or not. So I think there should be some caution in interpreting all of them, but that's about it. Right. Back to Dr. Chetan. This was the Monarch-E prognostic utility of ctDNA detection. A very interesting paper for me because they looked at a Monarch-E subset of around 1,400 patients in which whole exome sequencing was done for 1,100 patients. 910 had a overall ctDNA cohort in which 889 had serial follow-up as well. Now, serial, next slide, in this study was defined as doing Signatera at 0, 3, 6 months. Okay, so you have serial DNA. They found that the patients who had positive baseline DNA, ctDNA, did much worse. Look at the curves, red and the yellow. Very bad outcome when you have a positive ctDNA. Look at the other curve. There, if you had a positive which became negative, you still did okay. If you had a positive, a negative that became positive, you did badly. If you were positive, remained positive, did very bad. This was the monarchy update. Soumya, your take on this? Because remember two things. Colon, we saw that those who do badly. Logical. But a positive converting into negative seems to do okay. So even if you're positive, you still give your adjuvant. That's my take on it. Soumya, what's your take on this?
The trial is very good. It seems like it is prognostic, and the positivity rate was something like around 8% upfront. And also that was a bit low because they are randomized post the adjuvant therapy. So that's why the percentage is low. But the graphs really separate well. And if you look at the yellow line, the negatives, they are relapsing more in the later part. And if you look at the positives, they are relapsing a bit earlier. So as of right now, it looks very prognostic.
So you're saying it's only prognostic. As of now, you won't change your treatment based on this. Okay. Dr.
Right.
Chetan, if I can ask you the same question. What this tells us is, we always wonder if it is positive, is it worth giving any treatment? And here it shows. If you're positive, you take treatment, you become negative, you're still doing reasonably okay. Not as good as if you're negative, but otherwise still okay. Do you agree with that, or the numbers too small to decide anything?
Yeah, so the conversion part is really interesting, that if with treatment, if it is converting from a positive to negative and still having a decent survival, not as good as those with negative, I think that is important for me. So it is prognostic, no doubt about it. And if my treatment is going to help someone, why not?
Very good. Next slide. Dr. Amish, we have Signatera coming into India. Should we start doing it? Because look, the numbers
Dr.
are
Vamshi,
small.
sir, sorry to interrupt. You have 5 minutes for your
Thank you so much. Thank you. Dr. Amish,
Vamshi, this is a very, very tricky paper. Trust me, because when I read this paper, it actually is highly significant paper, what you have selected. But really, we don't know what to do today. Tarini has written that some of these positive abemaciclib makes it negative. We really don't know whether it is abemaciclib or abemaciclib plus AI. It is very difficult to say. My only point, which was highly significant, that on the paper which remained positive, 100% of them had an event.
correct.
I think that frightens me. That
Yes.
what do we do with these patients? Because all 46 patients, all of them who kept remain positive, they all had an event. What do we
Correct.
do with them? Do we stop CDK? Do we go for second line? We really don't have an answer to that. So I really do. I'm scared with this paper, but I don't have a solution right now.
Okay, so I think that's the biggest takeaway for all of us. Do we do it? Because there are patients who are coming and asking us that shall we do it or not? We just don't know. So I think that's the answer. We just don't know at this point, but I agree with you, it is scary. If a person does come with this report and says, I'm positive, look, it's bad. Good thing is it's only in 50% out, 50 patients out of around 900. So that is the only saving grace in this, right? Next slide. So in case we forgot, next slide, next slide. Next slide. Again, we have discussed. So our patient was offered abemaciclib, because you can go back one slide, please. So our patient was offered abemaciclib. It was refused in view of the age, and somebody said questionable benefit. Now 10 months of letrozole, patient got a PET scan done, and this is what we found. There was an IMN node which has come up. It is 10 millimeter. You can see it. There's an increase in the activity in the bone metastasis. So this patient has relapsed in 10 months. So, this is a patient where if I had done a ctDNA, it might have been positive. I don't know. But this was a patient who refused abemaciclib, and it just kind of reinforces me, irrespective of age. If you're having high-risk features, I go back to what Amish said. If you have high-risk features, I think it's time we had this discussion with patients that, irrespective of whatever quantum, it's possibly not a bad idea to give them something. Okay, last 5 minutes. So next slide, please. I'll start with this very interesting paper again, which came on adjuvant endocrine omission in ER low percent patients. Dr. Chetan, do you omit in ER 1 to 10, or do you still give it with the idea that it may or may not help?
I offer it, but I don't know how much good I'm going to do.
Very good.
But
So
let me
this
be
is
honest, I really offer it. For anybody
I
more
agree
than
with you.
1%, I offer it.
Perfect. So in this study, the OS was 94% in the patients who got it and 87 who did not get it. And omission of adjuvant endocrine was associated with worse OS. So this makes me a little bit comfortable in giving it. Dr. Soumya, your take on this? Would you continue giving in 1 to 10? Or, there is contradictory data in this. There is a very big analysis last year from, I think, the Swedish or Nordic group, which said it did not help. But this was a paper this year in ASCO which said it helps. So what do you do?
Yeah, I will give them. I will give them. This is a reassuring test. We did give them from 1 to 10%. We always give them. So this is reassuring. Yes, this is still debatable, but as of now, I will still give them.
Okay. So Dr. Sahu is saying he was skeptical, but he has now called back 2 patients to start it. I think we give it for whatever good or bad. It does have side effects, which around 15-20% of patients do have side effects with adjuvant endocrine, but they're not long lasting. So that's my take on it. Next slide. So next slide. So this was another paper which was very interesting, which looked at the RxPonder study, and they actually looked at the serum AMH levels to identify those premenopausal patients who would likely benefit from adjuvant chemotherapy. So the way they did it was they estimated a lot of hormones, serum estrogen, progesterone, FSH, LH, and all. Those patients who were premenopausal, they tested all this. Next slide. And these all patients got chemotherapy, by the way. And they found that those patients who had AMH level of more than 10, this basically indicates a good ovarian reserve. Those were the patients who actually benefited from chemo. The other patients who already had low chemo reserve did not benefit. Again, a lot of discussion keeps happening on this point of whether the chemotherapy actually works by suppressing ovarian or actually doing something to the cancer cell. Dr. Amish, AMH is easily available. Would you do it now for patients and change your treatment, or do you think it is just hypothesis generating at this point?
No, I think this helps me in my clinical practice, Vamshi. Because what happens is that even in Sudeep Gupta's paper, if you see premenopausal, postmenopausal, rather than that 50 and more than 50 was the cutoff. So a 51-year-old lady, she's not very sure about menopausal status, and if she comes with a high score, you really don't know whether to give chemo or not give chemo. You do AMH, and if the AMH is more than 10, you really know that the ovaries are functioning well. You are a little more confident about it. I think this helps me in my clinical practice.
Dr. Chetan, would it be a test you would start doing? Because again, AMH is easily available. It's not something which is different, but it's an interesting paper. I have never looked at it, to be very honest. So Dr. Chetan, your thoughts on this paper?
I think it is interesting because a lot of patients who are perimenopausal have been started on tamoxifen. We don't know when they are, somebody is on, say, GnRH analog and TAM, and we don't know whether they've actually hit menopause or not. So if I have an AMH level which is high, I know this lady has a fair amount of ovarian reserve, and I would aggressively pursue ovarian suppression rather than just be happy to take tamoxifen its course.
And also it will help you. You are more confident your chemo is going to help, looks like from this study.
Yes,
Next
definitely.
slide.
Definitely.
Next slide. Right. So again, I think this is an interesting paper and something that we will do. It's cost only 1,800 as Dr. Ajay Bapna has pointed out to us. So it's a cheaper test and it does seem to help. I think at least for selected patients, I will start doing this. Next and last paper, last slide. This is about fertility in patients among breast cancer survivors attempting pregnancy. And very interesting, this paper, again, this is not something we had prospectively looked at. So this paper looked at it prospectively. And what they found is that out of 1,213 eligible patients, 197 attempted pregnancy. And in that 197, almost 70 to 80% actually got pregnant. So 73% reported at least one pregnancy after diagnosis. So that was the paper that it showed. So Dr. Soumya, your own experience, patients getting pregnant, do you think it happens? How easy is it? Or do you offer patients fertility preservation? I mean, oocyte preservation, other tests.
Yeah, we do have a good CHR that requires a good center of human reproduction and infertility. If it is there with your junior hospital, then we do refer them. And this paper again shows how important it is that you have to refer the patients for a oocyte preservation, because in this paper, if the patients were concerned for fertility or they had done a oocyte preservation, then they had a higher chance of having a pregnancy. So that was a positive predictor. Higher age was a negative predictor in this particular paper. So definitely you must counsel the patients for suicide preservation or embryo preservation.
For me, this was interesting because now we know that yes, if a patient is younger, there is a chance of pregnancy of almost close to 60-70%. That's not a small number. It's actually a good number and we should encourage our patients. So that was why I picked this paper. So I think this was all that I wanted to discuss. Next slide. Next slide. And that's the paper. I think I finished in time. So Dr. Sahu, over to you. If any questions are there, we can take it. Or else if you have any...
I think the AMH thing, I think Dr. Chirag had a comment for, which he can open up and ask the thing. And Chirag sir, you are not sure of something, you posted that. And by the time he finishes, Tarun, I'll request you, a good thing is we have 200 attendees, and that is something all of us would love to. Tarun, if you can open up the chat at least to all the attendees, so that
I'm just doing that.
Yeah, if you can do that, then it really comes in.
Yeah.
And
in the meantime,
Sahu,
Dr. Sahu, there's I think couple of questions in the Q&A. So Safalta
can you do that?
Yeah, Safalta wanted to know whether we can use AMH instead of E2 FSH level to detect menopause. I think that's not what AMH does. AMH is used for detecting ovarian reserve. So ovarian reserve is good. That's what it is looking for. As of now, the definition-wise, still E2 FSH holds good for detecting menopause. The second question is, elaborate on the approach of premenopausal patients who receive OFS, what hormonal drug to start and when to start and how frequently to use and when to switch. I think this is beyond the ambit of today's discussion. I think somebody can answer it.
Vamsi, if you can just, after your panel, just type the answer so that this question also answered.
I will do that.
Yeah. So one more thing I wanted you to clarify for all of us. So why should then one do AMH, and where do you think AMH is there in the practice today? That could be the take home from your side.
Again, this is a small one abstract. And honestly, just based on this abstract, I'm going to change practice. Where it will help me is, supposing we have a patient where we would like to give chemotherapy, AMH is high, it is likely to benefit them more. That is number one. Number two, if AMH is high, it indicates better ovarian reserve. That's the patient where I will push for giving ovarian suppression also. So those are the two indications where I will be using this test as of today. We do have a question which has come. Minimum.
I'll type it. Yeah, I'll do that. Chirag sir, your last comment on AMH part, Vamsi told he will use it to decide chemotherapy probably if the AMH is still there. What is your take?
I think whether to give chemotherapy or not, it depends on the clinical and the molecular factors that we already know. We have been discussing over and over again. But if the patient's ovarian reserve is poor, I may not use the ovarian function suppression. If the ovarian function is good, I will be using OFS for this patient. I mean, that's how I will take rather than for deciding chemotherapy.
Okay. Amish boss, your last take on AMH, because there is like a diverse opinion that's coming through. So where would you use AMH?
Where this abstract have used, where we are borderline for understanding menopausal status, because the PONDER-X study had clearly shown that postmenopausal 15 to 25 oncotype DX score do not benefit, while premenopausal benefits. So if we have this group where oncotype DX is between 15 to 25, and we are not sure of menopausal status, we do AMH. If it is more than 10, we know ovary function is preserved, and we offer them chemotherapy with little more, conviction. This is what this paper, I will use it in my practice.
This is the setting which you'll use it. That's what it should be. And we stick to the paper. That's what it should be at this point.
Yes.
And as the data more evolves, probably we can then replace it with the other not uncertain and costly test. Absolutely. I think the answer, that's what is put forward. We'll move on to the next panel, and we have Dr. Nitesh. By the time Nitesh loads his 5 slides, minimum duration of hormone therapy, it is as per the patient and the doctor. The only concept is push your hormone therapy more as much as possible and delay the pregnancy as much as possible. But this is something that you would not get a level of evidence. But more the hormone therapy continuously given is better. That's how, Dr. Manas, I hope you have got the essence of what your question was. We'll be answering the other things. By the time we'll also opening the chat, but we will answer. We'll only take pertinent chats, not everything. Please, we'll have the next panel.
Thank you. Thank you, Dr. Sahu. Always a pleasure. This is deep dive. I'm very honored to actually have on my panel Dr. Ajay Bapna, Dr. Bishwas. Dr. Bishwas, are you there? I couldn't see you earlier. Is Dr. Bishwas
Is there?
Yeah, I'm there.
Yeah.
Okay, hi. I'm Dr. Akhil Kapoor. Akhil, are you there?
Yeah, he's there. Akhil is there. I saw.
Yes, sir.
Excellent.
Yes, sir. I'm there.
So let's go into it. Not so much ASCO and ESMO, but generally what we have seen is EBC not equal to 4 basically. But Akhil, let's start with you. Would you include oligometastatic when you're treating this EBC kind of concept in HER2 positive disease? One bone met or one liver met.
No. Uh, Oligometastatic disease, if it is hormone receptor positive, that is a different thing. If it is HER2 positive, it is yeah. So it's HER2 positive. It will be treated with might be treated with curative intent, but still it will deserve the entire treatment for metastatic disease.
Dr. Bapna, would you kind of more
I think
treat it like a node positive, a locally advanced breast cancer, HER2 positive, or more like a metastatic disease?
More like a metastatic disease. If we go exactly as per the MD Anderson Cancer Hospital's definition of oligometastatic, it is a spectrum in between early breast cancer and the metastatic disease. And it is basically a subtype of metastatic disease. Though the rapidity and deterioration which patients show on oligometastatic is low, but it goes towards metastatic, not EBC at all.
Yes, sir. Completely agree.
Dr. Bishwas, this is really what I'm coming to, that the, for example, ESMO guideline is divided this into a locally advanced breast cancer, HER2 positive EBC, and a very early breast cancer. And I think this is what I was asking, where would you put these patients into, more towards the right or more towards the left? Would you look at residual disease and then treat with TDM1, for example, or you would do something differently?
So CT1N0, I think surgical.
No, I'm saying oligometastatic disease. Where would you put that?
It will not be definitely in the left-hand side group, but it will be on the other side of the group.
Okay.
Yes.
Okay.
Yeah.
So you could potentially treat it like a locally advanced breast cancer,
Yes.
except I guess we will be discussing further about
Absolutely.
what to do. Okay. So let's start with a truly EBC, which is the node negative group. And most of us at the moment are following this kind of a dictum where if surgery is possible, we are going ahead with surgery. And if it is really a very small tumor, less than 3 centimeters, according to APT, we are actually doing adjuvant APT.
Yes.
Slightly bigger tumors, we sometimes operate first and give chemo later. Very rarely do we do other way around. So, Dr. Bishwas, let's start with you again. T1C and 0 requiring breast conservation, patient is very keen. Do you see the role of neoadjuvant chemotherapy here? If so, what kind of drugs?
Yeah, so T1C, so probably I will err to using as a neoadjuvant rather than adjuvant. So till T1 okay, but T1C probably, because many of the trials have included T1C also. So I think I'll include T1C as a neoadjuvant.
And if this was not breast conservation, this was a MRM case, then?
Probably that won't change because I'm looking at a pathological CR rather. So my treatment at the end of systemic therapy and the local therapy is done. So my treatment, further adjuvant, extended maintenance treatment will differ.
And so for that case,
Hitesh, I slightly differ from Dr. Bishwas.
I'm going to ask you exactly, sir. I thought you would.
So the patient by surgery we have put them into remission. It is a surgical complete remission, and we have now a 10-year follow-up of APT. There is only theoretical possibility that these patients on NSCT will be anyways having the resistant clone. So 10-year follow-up, 93.4% overall survival. I think surgical complete remission is helping all these patients. So
I will only give neoadjuvant chemotherapy to only tumors who are more than 2 centimeter, not below 2 centimeter. 10-year follow-up is convincing enough.
Okay, Dr. Akhil Kapoor, I think over to you. Patient requiring MRM, not conservation surgery. Patient is T1C. Would you consider neoadjuvant therapy?
Sir, here again, I will say the decision of BCS versus MRM is not changing the choice of whether we are giving anesthesia or not. To be frank, it is the T1C. We are not very. The data is not so strong, and we can avoid some of the stronger chemotherapies. We can follow APT in the adjuvant. So we counsel the patients. Most of the time, they tend to choose upfront surgery in such patients. That is what is our experience.
Quick take, Dr. Bapna, SNLB before or after?
Sorry? Yeah, yes, before.
Before. You do before?
Yeah.
Dr. Biswas?
Before.
Yeah, before.
Akhil?
Yes, sir. If it is required, it should be done before.
Wow, okay. I will ask maybe others to talk in the last 5 minutes. I'd say 5. How many of us do SNLB before in patients who we are giving neoadjuvant chemotherapy in practice? Okay, so Dr. Bapna, again to you. So this is a de-escalation. This is a 80-year-old, otherwise very fit, but this is not 3 centimeter under. This is a 4 centimeter node negative tumor. Let's say for the sake of argument, you plan to give, I mean, she's debating between neoadjuvant chemotherapy and surgery. What would you do and what would you use? She's 80.
So at this age, 80 year, they need to be managed a little bit differently from the younger patients or maybe 65 or 70 year, because here we need to take help of the various online tools to, to know the first of the life expectancy we need to know in these patients. We need to know the prediction about the chemotoxicity, and we also need to know the efficacy. So these all tools are easily available and calculators are available online for these patients. The comprehensive geriatric assessment is a must before deciding any kind of systemic treatment.
And what kind of cutoffs are you looking at? I mean, what percentage benefit would you go ahead and give, and what kind of regimen?
If the Charlson morbidity index is coming out to be 2 or 3, I'll be skeptical and I'll be not giving the polychemotherapy. And in Charlson morbidity index 1, I think the taxane and the trastuzumab should be sufficient.
And if you're struggling with that, you do monotherapy, as in you would go for surgery straight?
Yeah, she will require after NSCT. And there is a lack of data for the dual anti-HER2 blockade in this group of the patients, because these were represented very less in these trials. And use of pertuzumab is definitely investigational, and trastuzumab is well established. And carboplatin, I will be very skeptical in giving to these patients.
Like as you said, yes, as you said, so 80 years, otherwise fit, but many a times those who practice geriatric oncology will differ. So many a times we have seen the patients are fine, 80 years, maybe no comorbidities or comorbidities are well controlled, and you start on therapy and you don't know actually the physiological reserve, and you just land up in a problem putting a carboplatin. So rather in such patients, even everything is fine, then I would err to put this patient on surgery and put on adjuvant like APT type. So I don't know, because the echo might be holding on, the patient GC might be holding on, but few cycles later, the patient's GC might go down and she may not be fit for therapy. So we have to respect the biological age also.
Yes.
You're thinking surgery first.
Completely agree.
So Akhil, this was the De-escalation trial that actually was very interesting. They basically divided the group into up to 5 centimeters. Do note it's up to 5 centimeters. And they gave 12 weekly paclitaxel or docetaxel and escalated to HNP in that group, and then did conservation and obviously pathological CR. They do much residual tumor, they escalated therapy. But this is up to 5 centimeters. This is not how the initial trial went up to 3 centimeters. So in a 80-year-old, would you be tempted to say, let me do a APT kind of therapy with HNP and compensate for the lack of chemo, at least to begin with. Okay.
Yeah. So if we see, sir, in such patients, neoadjuvant treatment with taxane plus trastuzumab is what is most commonly utilized. And we usually, unlikely the patients will tolerate anthracyclines. Unlikely the patients will tolerate the combination of TCHP-like regimens. The preferred drug which we utilize in NSAT in such patients after 3 centimeter is taxane plus trastuzumab. That is what is most commonly utilized in our practice.
And Dr. Bapta very rightfully said that P was not tested in this group. What about the use of P in this group? If you have to use neoadjuvant up to 5 centimeter, would you use pertuzumab because you can't really use anthracycline and you don't want to use docetaxel and carboplatin?
Yeah, use of pertuzumab is investigational in this age group. Two chemotherapeutic agent, endoxan we can add in place of the carboplatin, and taxane, cyclophosphamide, and the trastuzumab. That will be sufficient for neoadjuvant chemotherapy as well as if you want to use it in the adjuvant setting.
Akhil, would you use pertuzumab? Akhil, would you use pertuzumab?
Pertuzumab is investigational at this age.
I'm asking Akhil and Dr. Vishwas's view on.
I won't use pertuzumab in this case.
Yeah.
So pertuzumab also leads to a significant amount of diarrhea in our elderly patients. That is what we have seen in our practice. So in older patients, if pertuzumab is not strongly recommended, I will not utilize. So and this is a borderline area with less data. So yeah, completely agree, sir. Will not utilize.
DCIRG-01 trial, the carboplatin was omitted in these patients and outcome was really good.
Yeah. Okay, so I think what we have said so far is that
in such a group, we try to. Yeah. Please, sir, go ahead, sir.
No, so I think what we have agreed so far is that while it seems very tempting that a patient has a bigger tumor, pertuzumab has less data. So if the patient is fit enough, that's a different question. Otherwise, maybe surgery is still the best option in this age group, followed by adjuvant therapy, where that's possible. So with that, let's move to the bigger group, which is the question of the plenary abstract on adjuvant therapy. Affinity, there was a long-term follow-up of Affinity, which is adjuvant therapy, and it showed a difference of almost 2.3%, but the hazard ratio is 0.81 with confidence interval just about touching 1, and P was also not significant. Dr. Bapna, your view on this? This was a long-term follow-up.
Yeah, it is a long follow-up, and it has shown consistent benefit in the node-positive patients. So it is not a bad idea to use pertuzumab in node-positive patients. You should use looking at the long-term follow-up and the benefit both.
Dr. Vishwas, you've started using this in all node-positive patients who end up with surgery, and these happen to be often a slightly more elderly population. Now we are going other way around. We're going neoadjuvant therapy, pertuzumab, not much data in the elderly population, but actually in the adjuvant setting, if somebody does have a largest tumor, node maybe N1, would you use, because there's long-term survival benefit as well, small but there.
So yeah, I'll tend to use, and now if the genetic story goes right, then probably the usage will more.
It is available. It's not a far-fetched dream now anymore.
It's not a far-fetched dream. So this was a node-positive cohort which you're talking about, and because this is long-term data, I think this is quite interesting and important, and we will use more and more, I guess, but we have to really differentiate the node positive from negative because the benefit was very, very limited in that group. This was a subgroup analysis. This is very interesting. Akhil, I'll come to you with this. This was in San Antonio Breast Cancer 23. They essentially did a sub-analysis. This was retrospective for sure. And they looked at the entire subgroup of fish high, ER positive, fish high, ER negative, fish low, ER positive, fish low, ER negative, and saw whether the real benefit was related to this. Any thoughts on this?
So I think this is just a retrospective teasing of the data.
That's correct. Correct.
Yeah, I'm not sure whether it has any clinical significance in the real practice.
Essentially, it said that
That is my
the
take.
whole group. Essentially, it said that the whole group benefits. There's been a lot of debate on ER positivity and role of pertuzumab in the neoadjuvant from Trifina, and this is to look at the adjuvant data and look at ER positivity and negativity, and saying that the entire group benefited. So we are asking if this group not in the adjuvant setting if they were positive.
Dr. Shyam Agarwal wants to say something, probably.
Okay. Dr. Vishwas, you were saying something?
No, I said Dr. Shyam Agarwal probably wanted to say
Okay,
something.
I think that was just his mic was on. What's your view on this, Dr. Vishwas?
So I'm
Would
also
you-
not
would-
sure. So
Okay. So I
maybe
think what we're hearing is that we will give it to everybody who's not positive if they can afford and if they can tolerate,
right,
because there seems to be a benefit there.
right.
This is an 80-year-old, otherwise fit 4 centimeter. Question is chemo escalation versus HNP escalation. Where would you escalate for chemotherapy? Maybe 80 and maybe think of 60 as well. And where would you do HNP escalation? 80-year-old fit 4 centimeter, node negative, ER positive. I think this is what I was coming out from that subgroup analysis.
Yeah.
And same way, ER negative, would you think about it differently? 80-year-old, otherwise fit 4 centimeter, node positive. We've just discussed that. So coming to this new adjuvant group, this was a big chunk. 60-year-old, otherwise fit 6 centimeter, node positive strongly. New adjuvant, what would you use? Dr. Bapta, let's start with you again.
I
What
think
would you use?
I think we have conclusive data on the pathological CR with various regimen, and TCHP is the standard of care these days. So these patients should be offered a non-anthracycline based neoadjuvant chemotherapy, preferably TCHP.
Correct. So I think this is train 2. Dr. Bishwas, do you want to tell me what's your take on train 2? I think this is a very interesting, very clear study.
Yeah, so that shows that these are patients where you can always omit anthracyclines. So that you may not pull along anthracyclines, though it is HER2 positive. So TCHP is good enough, and you are not adding the long-term toxicity also.
Akhil, any place left for TC of anthracycline without TCHP or with TCHP in the world today?
So, sir, what has been our practice and European guidelines, even in patients who are node negative, no doubt we can avoid anthracyclines. Patients who are node positive, there is still some consensus in European guidelines which suggest utilizing anthracyclines. So I think if their disease burden is high, nodal burden, I see N2, N3 disease, I would be going with the usual more conventional regimens rather than TCHP.
Because this specifically, and that's why I put the subgroup analysis forest plot here, is specifically I'm trying to show the node positive as well as stage 3. A curve is still towards, although you can say confidences, but the curve is still towards PTC without anthracycline benefit showing. So essentially train 2 to my mind was quite a strong and non-anthracycline push in HER2 positive group at least. Sorry. So this is the value of neoadjuvant. This came very interesting. Based HER2 positive breast cancer systemic analysis, they did analysis, said the same thing. At comparison of anthracycline versus non-anthracycline, there was a clear benefit of non-anthracycline. My guess is there's some toxicity overlay in this as well. 60-year-old otherwise fit N2 pathological complete response. We started with TCHP, as Dr. Bapna said. What would you do in the adjuvant setting? What would your duration? What would your choice of treatment?
I think the choice of post-surgical management will depend on what was the pre-surgical staging.
This was 6 centimeters N2 to begin with.
Yeah, so we will continue with the trastuzumab and pertuzumab as maintenance.
And 1 whole year, no, nothing else.
Yeah.
Dr. Vishwas?
So we are given already 6 cycles, so another 11 cycles. So to
Yeah,
complete 1 year.
pertuzumab and trastuzumab.
And we'll
Pathological
continue
CR doesn't,
also because of
pathological CR doesn't make you want to drop pertuzumab at least.
It is a
No,
pre-surgical
no, sir.
staging which will
This
decide.
is N2 disease. Yeah. This is N2 disease, sir. We'll not take risk here because the patient has responded well to the Trastu plus Per2 based treatment. We'll continue that in adjuvant setting.
Yes.
This was very interesting Peony trial, which basically looked at neoadjuvant pertuzumab and continuation beyond adjuvant, and you can clearly see data. And I think this is what Akhil and everybody else is saying. I think I have very little time left. Adjuvant TP versus T alone. This was a very interesting. I think this question does keep coming up. Why don't I take the pertuzumab out after neoadjuvant in pathological complete response? This is the only paper I found. This was in an abstract form. And in all patients at 3 years, RFS did not differ between the two groups, but this is not divided by nodal disease. We do not have N2 versus N1. We don't really have the indications here. As I said, this is not a full paper. But I guess as more information comes out, this will be a good question that in pathological CR, can we de-escalate at least the pertuzumab or not? In last few slides, 60-year-old, otherwise fit, N2 residual disease. What would you do in terms of choice of therapy? Let's start with Akhil on this one. I think I'm essentially asking you about TDM1 versus continuation of pertuzumab.
So definitely, if residual disease there and patient is fit, will offer adjuvant TDM1 to this patient. Now the trials of adjuvant TDX versus TDM1 are ongoing, so we'd like to enroll the patient in trial. And likely next 2 years, we'll see that adjuvant TDX is much better than TDM1. This is what is going to happen. That is what you think.
That Dr. Purush Manik will say in the end. But this is very interesting. I want to show something before I come to Dr. Bishwas on this. So this was Catherine, 3 years, 88 versus 77, and overall survival. We have long-term data now on Catherine. We are all looking very positive. Up to 7 years, the benefit is still there, and second OS is still positive for all comers. But let's look at the pertuzumab data. This is very interesting that at 3 years, those numbers are almost identical. Look at 76.8, 88.3 versus 77 and 88.3 there. So it is very interesting that continuation of pertuzumab, the numbers at 3 years were similar. What's your take on this?
Dr. Nitish, so the problem is that in the Catherine, 18% patients so either had to discontinue because of the toxicity of TDM1. So what do we do in those patients? Because 18% is a big number actually, if you see that. So though probably in those patients, you just go back to again pertuzumab. So maybe, I don't know. So
I think this is one of the key points that Peony has brought about, that pertuzumab continuation also helped in the patients with residual disease. Dr. Bapta, your take.
I think the Peony is the only phase 3 randomized trial where they use only 4 cycles of neoadjuvant, pertuzumab.
Followed by continuation.
We can't compare it with the regimen which had 6 cycles of trastuzumab, pertuzumab. So we can't compare oranges with apples.
So your take, if a patient can't tolerate TDM1, would you put them back on pertuzumab and finish 1 year of therapy?
I think, yeah. So TDM1, I think I'll continue with TDM1.
So if patient is not able to tolerate, definitely we'll shift back to Trastu plus Per2 combination. That is what is being done in the routine practice as well, I think. And the trial also gave the option.
Okay, so I think we'll have 5 minutes. As Dr. Sahu said, we'll open the question for discussions in the last 5 minutes. My overall take, Dr. Sahu, is that we are still very keen on doing surgery where we can in the truly very small node-negative patients. I do think that elderly patient and pertuzumab in neoadjuvant is a matter of concern, and we should take that very seriously because the data is lacking. We don't know where the benefit is, and we sometimes do have to use it when we have to use it. But in the patient who are getting neoadjuvant TCHP, I think the Peony was one big thing that has happened in the last year, which really said, because we've all struggled with TDM1, that actually pertuzumab can be continued. Although I do think that Catherine is so strong that where TDM1 can be given, it should be given. Dr. Sahu?
Yeah, so we have 5 minutes late 10 to go for this. I think Dr. Shyam Agarwal sir has a question. I think one of you can take it. Sir, you can ask, sir, please.
Yeah, I think Nitesh, you started with the oligomets. So if you get a PCR, after you started TCHP, but the question is, how long do you give the adjuvant in oligomets?
So what would you do, sir? Because
especially Shyam sir told that if I achieved a PAT-CR, because you have operated the breast, that's what it is, sir.
So I'll say this again. So patient started with a single liver metastasis. You put in a clip, you did a TCHP, patient had a surgery, had a liver resection done, and there was no disease. What would you do next? So Dr. Shamgal, what would you do? I personally would continue HNP for 1 more year and finish and then stop there.
I think oligometastatic disease should be treated with a curative intent. The way we are managing the other stages, we should offer them the same thing.
No, Ajay, I think for the curative intent, you're stopping at 1 year. But
yes, we will be stopping. We will have to be, and we also need to give the local ablative therapy.
No, so how long to give the adjuvant HER2? That is the question.
Just as you are giving the other patients who are not overtly metastatic.
The panel is speaking of that, give it for a year as you treat the normal early breast cancer.
Absolutely.
Especially the situation as Nitesh told that you have been operated the liver single, and that is also in PAT-CR, right? That's
correct. That's correct. So I think what we have to do is, to my mind at least, we have to take a call on day 1 whether we are treating this as a stage 3 or not. And if in stage 3 we are giving it for 1 year, it would be very difficult to actually give it for longer. Of course, there's residual disease. There's a different question. Amish, you had a point to make.
Yeah, I think in absence of data, we are all conjecturing, Nitesh.
We are. Of course, we are.
I think to answer Dr. Shyam Agarwal sir's question, in absence of data, even if it is one metastatic, we know breast cancer is a systemic disease. I would continue anti-HER2 therapy, and it will not be adjuvant, although the intent may be high palliative stroke curative, but we don't have data to stop at 1 year, 2 years. There's no way we can take that call.
Right.
So just a quick question to you before I go to Chirag for a second. But in your mind, you have operated on that patient, keeping in mind that you're going to continue HNP for rest of their life?
So you have a very valid point, Nitesh. We are operating here again, oligometastatic, operating with the curative intent, but we don't have the data. So logically, what you are saying is right, that you treat them as 3, but we don't have data. And HER2 is such a strong oncogenic driver, Nitesh. We all have seen that when we stop. Why do we continue for 7 years, 10 years, and 12 years trastuzumab?
It comes back with a bang.
Absolutely.
I agree with Amish. I agree with Amish that we should continue for long.
I think, sir, the line has to be somewhere in between.
Okay.
If you have done extreme
in between, kahan pe Tarini?
मैं बोल रहा हूँ situation बोल रहा हूँ. If you have taken an extreme situation like operating and then also a PAT-CR type of thing, you won't have a trial for that. You can stop, but if someone has not and a single lesion wants to continue, can. But I have a point that if you have done a surgery, done a metastectomy, and have a PAT-CR, you are within your rights to discuss stopping, although there's a high risk of relapse. You won't get a trial for that. That's my
becomes then the contradiction. If you are doing surgery in these patients, it's a contradiction then.
So, okay, one thing at a time. First, Chirag, hand was up. So, Chirag, please make your point, and then I'll make my point. Chirag.
So, the same line, if the patient has been operated, patient has been rendered no evidence of disease, we have the data in RCC in pembrolizumab trial, where we are giving pembrolizumab only for 1 year. So if the patient is so I agree that we don't have any data like in renal cell carcinoma, but I just wanted to find out from some of you, what would you do in your practice? If the patient is NED for 1 year, 2 years, 3 years, 3.5 years, will you take some time or you will continue?
I'll share my experience with 3 patients who we have stopped. One patient was where we planned to continue. COVID came, we stopped. So now 4 years, she's disease-free. The other patient, we actually planned to continue. We continued for 2 years, 2.5 years. COVID came, we stopped, and we haven't started. These are two patients. And the third patient who chose not to have after having it for 1 year because she said, I mean, the same logic which I was applying earlier. Having said that, there are another 4 or 6 patients where I continue because of what Amish was saying. It's very difficult to stop, especially when you give the choice to patients. Most of them don't take it, especially Herceptin alone. I find HNP very difficult to give after a couple of months, especially with skin getting difficult, exhaustion starts in, and I think the other side effects will start developing. I think my time is up.
I think we'll stop here and the discussion can go on the chat. One thing only, as Dr. Sendil in the next session is his. It's a sponsor session by Astra, and he'll be having a panel on the HER2 low. So by the time he loads his slides, he can answer this question. What he does for the discussion that was going on. Quickly, half a minute, Dr. Sendil.
I will stop. I will stop at 1 year. So if I've done surgery, that means I'm treating with curative intent. So that intent remains curative, I will stop. We can argue saying it will come back and all that. So, but I will stop. I agree with you.
And as a moderator,
no.
As a moderator, I'll say, no. As a moderator, I'll say, as a moderator, Senthil's word is always final.
मैं वही बोल रहा था. Amish boss, now you cannot say anything.
As a panelist.
You told when Senthil speaks, you are final. That's a final word. So that's it.
Hey, Amish. Lovely.
Okay.
Sao, can I share my screen?
Sure.
Yes. Thank you. Okay, so it's very exciting. I think having all the thoughts on the screen is simply very thrilling, and the kind of discussion that's going on is very stimulating and exciting. I hope we will continue to have one like that. I am privileged to have, thank you, Sahu, and thank you, AZ, for asking me to do this panel. I'm very privileged to have the organizing chairperson himself as part of my panel, Sahu, and then the organizer of the Best of ASCO, Biswas, and then Chetan and Bharat Vaswani. Bharat, are you around? I saw Chetan around. Sahu, is Bharat Vaswani? Yeah, I can see.
Present, sir.
Okay, lovely. Thank you. Okay, so we'll do case and then try to discuss a few points. Now, this is a fictitious case, so if you find some mistakes in terms of the way things have happened, don't bother, we will pull it back. So this is 2017 when this lady, 50-year-old, postmenopausal, so we won't do the anti-Mullerian hormone at this point in time, we'll accept that it's postmenopausal. She had a breast cancer, IDC grade 2 ER/PR positive, HER2 was negative, 5 centimeter T2. She had docetaxel cyclophosphamide into 4, followed by breast conservation, radiation therapy, adjuvant letrozole. Her germline panel was negative. She was lost to follow-up for 5 years, but I assume that she was taking her treatment. She presented in 2022 with back pain. An MRI was done, which was suggestive of bone metastasis. Assuming that she presented again, assuming that she was not taking letrozole. So on PET-CT, there's a pleural-based soft tissue. There are pleural and parenchymal nodules, and then mediastinal lymph nodes, hepatomegaly with multiple lesions, the largest one being 6 centimeter. You see that lesion that's sitting there. Lytic lesion with soft tissue component, medial aspect of the clavicle, and multiple metastasis. So large pleural-based, large liver metastasis, multiple liver metastasis. Though these are not very symptomatic, liver function is normal. Back pain is the only symptom. A rebiopsy was done from the liver. The GATA was positive. Now it's ER90. Interestingly, we generally expect it to go down when you rebiopsy, but it was 90 and 85. HER2 was 1 plus. Ki67, 60 to 70%, and the GATA3 was positive. So Bharat, you're on my screen. So typically rebiopsy, what other tests would you do in a situation like this? Are you happy with what's been done?
Actually, for my first line, yeah, I think I'm happy with that thing. What for first line, PIK3, yeah, VIK3 mutation, probably for the later part of my treatment. ESR1 also actually for the later part of my treatment, second line after first line. First line, I think there is no controversy, sir. So I'll be happy with the reports for starting my first line, but definitely I'll like to see the PIK3 mutation and maybe a ESR mutation. And you have already told that is.
So how does the PIK3 like? How does PIK3 help you immediately, Bharat?
Sir, no, not as a first
BRCA
line.
germline, BRCA is negative. How does the PIK3?
Yeah.
Okay.
No, sir,
first
not
line,
as a, what I wanted to tell is first line, I won't have anything. I'm happy with the report for starting my first line. It is only for the later lines of treatment I may require, not for the first line, sir.
Okay. So, fine. So you don't want to do an NGS now. So is that
no?
Do I assume that to be right?
Yes, sir.
Oh, you don't want. Sahu, you agree with?
I missed one line of yours. So the patient had stopped letrozole for last 4-5 years. That's what you spoke.
Yes, that's right.
Yeah. So typically we're taking at the upfront hormone positive metastatic cancer. So I think I'm fine with this, and I would proceed forward with this report. I proceed forward with this.
Yes.
But the point is, would I do a rebiopsy? I usually do it nowadays. I've started pushing more of rebiopsies for patients who have accessible sites of metastasis.
Okay. So if you have a rebiopsy and there's a change of phenotype, which one do you use to decide on your treatment, Sahu? Do you use the present one? Do you use the previous one? How do you
Depending upon if there is a loss
let's say the ER became. Yeah, go ahead.
Yeah, please. If there's a positive, once positive, I'll definitely consider that, and that will be done. But it is more pertinent for patients for HER2 positive rather than the hormone positive for the rebiopsy report.
Okay, so when you rebiopsy, let's say the HER2 was positive at the time of initial presentation, but it became negative now. How would you act in a situation like that? So initial diagnosis was positive.
Okay, I would not. I still take it as HER2 positive to start
with. Yes.
But the gain of receptors would make me change my treatment.
Okay, so loss of receptor, you will continue to use the HER2 positivity for your treatment decisions. So let's say this lady was HER2 positive to begin with. Now it's ER90, PR85, and the HER2 becomes negative. What would your treatment be? Would you do a CDK4/6 plus hormone therapy, or would you do chemotherapy plus anti-HER2 therapy? In this lady, if this HER2 was negative and it was positive earlier.
I would urge towards giving a chemotherapy and HER2 targeted therapy.
Okay, so you would do chemotherapy and HER2 targeted therapy. Chetan, any difference of opinion?
No, but I have a question. Actually, I was just typing it in the chat box as we speak.
So, sure. Please go ahead.
Okay, you have one earlier HER2 positive, now became HER2 negative, you still treat. Second time a patient relapses, third time relapses. When are you going to say stop to HER2 directed therapy is my dilemma, which is something which always is, especially in breast cancer, because patients keep coming back with relapses.
Relapse again and again and again. Right. Biswas, would you like to take that? When would you stop the anti-HER2 therapy at all?
So I will just say the other way. So I had a HER2 positive disease patient. So treated, lost to follow-up, came back with disease after 2.5 years. We did a repeat biopsy. So this time she was absolutely ERPR positive, HER2 was negative. So I started her on CDK4/6 and hormonal agent. So she progressed at 3 months. So I did not repeat a biopsy. So I went back and started her on weekly Paclitaxel and trastuzumab. She responded.
To responded to HER2 directed therapy or weekly Paclitaxel?
Sir, once I had to always.
Okay, guys. Let's not get lost in this. So this is kind of a tricky situation when receptor was positive.
Many times it depends upon the clinical situation.
In principle, Exactly. So here is the situation. Even if it became negative, I would still rely upon that HER2 positivity at the time of diagnosis and certainly do an anti-HER2 therapy along. But if it was a situation where she came with, just a few bone metastases after 7 years of treatment and I biopsy the bone, however reliable or unreliable that IHC might be, then I may be tempted to say, okay, this phenotype doesn't look like HER2, so I would treat with hormonal therapy and then challenge with anti-HER2 therapy if it didn't respond. But Sahu, in principle, is right. Biswas is also right that you need to take the clinical situation and the receptor status. So the general rule is positive at any time is positive, and you will use that in your treatment. So that's how it goes. So Chetan, to answer your question,
Yeah,
Sir?
Dr. Sham.
Yes, please.
So let's qualify that it's only Enhertu when you're talking about HER2 therapy, not
No, we are not talking
trastuzumab.
about, I haven't gotten into Enhertu at all. We are not talking about 1
No.
plus, 2 plus, ultra low or 0 now. We are talking about good 3 plus.
Oh, so okay. Your slide is 1
we have
plus.
not come. Yes, no. That was a hypothetical situation I was driving at. So let's come back to this patient. So it's 90, 85, and 1 plus. Okay. So all of us agree that we will redo the biopsy because there is some migration in terms of the phenotype. So this is showing migration for her low standpoint. We need to understand that if you are having a patient with ER positive disease, nearly half of them would migrate from HER2 low to HER2 negative or HER2 negative to HER2 low. The migration to HER2 positive is a very small percentage. It's only about 5%. If you have triple negative disease, that's not there on your screen now, that will be roughly around 35%. So the movement from negative to low and low to negative can be quite a bit. But movement from negative to positive or positive to negative is a very small number. That's about 5% for people who like to know those numbers in case they want to look at Enhertu. The next question is discordance. We always keep talking about this. How good is your test? So, Sahu, what are the chances of discordance? Suppose you do it in Bhopal and then you're sending it to a better lab in Bombay, assuming that Bombay is better. What is the discordance that you see?
Okay, with that the caveat. So there are two things.
Yes.
If we are looking at ultra low and 1 plus, there is a high amount of discordance. If you're looking at a 3 plus, the discordance will be very low. So people have to understand that the technicality of reporting now on ultra low and 1 plus, that is the tricky situation. That's where the real discordance will happen.
Excellent. So that in between, so saying that it's negative is easy, saying it's 3 plus is relatively easy, but classifying it as ultra low, 1 plus or 2 plus is where the problem comes. So that's where a lot of discordance is there, but otherwise we are generally taught to interpret HER2 as positive and negative. So the discordance is not much. So these are some reasons why that might actually happen. So what is your choice of therapy for this patient now? Chetan, so let me quickly revise that patient. It's a 50-year-old postmenopausal lady who was lost for follow-up. She was ERPR positive, HER2 negative. Now rebiopsy, extensive disease, ERPR, and ERPR is positive, HER2 is 1 plus. So what would be your treatment for this patient? Symptomatic with back pain.
So I would definitely add her on a hormonal therapy, plus considering her earlier HER2 positivity status.
No, she was HER2 negative. Sorry.
So then
that was
then it is ERPR positive, HER2 negative. So then it's hormonal therapy with a CDK4/6 inhibitor.
Excellent. Hormonal therapy plus CDK4/6 inhibitor. Anybody's got a different opinion? There any choice in terms of your CDK4/6 Viswas?
So CDK4/6 and fulvestrant, because he was already exposed to letrozole. Hopefully, say received for 5 years of therapy. Then
so it's 5 years, then 2 years of break, Viswas. So would you still put her on fulvestrant?
So we have to look at the BMD and see. So if the bone mineral density is fine, it's not symptomatic osteoporotic. So then so we can always put on any of the aromatase inhibitors also.
Okay, so let's for this discussion keep it as aromatase inhibitor plus a CDK4/6. Which CDK4/6 Viswas?
So bulk of disease, so now, ribociclib or abemaciclib,
okay.
Both choices are there.
Ribociclib or abemaciclib?
I strongly still believe, okay, Sandeep.
Okay, stop. Okay, chairperson, I mean, organizing chairperson has his choice.
Sorry.
Bharat and then Sahu. Quickly, one word answer.
Sir, data-wise, ribociclib.
No, one answer. Okay, ribociclib. Sahu.
Ribociclib, one answer.
Anyone will do. I still strongly believe the PFS data is equal across
anyone.
these.
Very good. Anyone will do. We'll not get into the intricacies of whether one is better. So still people are happy to use palbociclib. That's good to hear. So what did they do to this patient? This patient was started on abemaciclib and fulvestrant. Okay, let's not get into why fulvestrant was used in this patient. So this lady was not radiated for her back. She went on abemaciclib and fulvestrant. She had progressive disease in the liver after 8 months. Right? So there's progressive, I don't have a scan to show you, there's progressive disease in the liver. She had some response at the end of 3 months, but then progression at the end of 8 months. Bharat, what is your next treatment of choice?
Sir, very early progression. Here, what I told you, that I'll do a biomarker study, sir, to find out whether the next line option we have available.
Okay, PIK3CA is positive, ESR1 is positive, mutant. PIK3CA mutant, ESR1 mutant.
Alpelisib with a fulvestrant. If I have used a fulvestrant, then it is then
Yes.
probably again a AI. Because I might have used a AI because 2 years gap was there. So if I have not used the AI, otherwise
So what is it that you
fulvestrant with the alpelisib.
No, fulvestrant is gone now.
Hello, sir, voice.
This patient was on fulvestrant and abemaciclib.
Sir, I will use a alpelisib with my aromatase inhibitor. I may try AI again.
Okay, so you're going to do BiLeave. So what's the likelihood of getting responses to that, Bharat? This patient has got tons of disease
PFS of
everywhere.
around 5 to 7 months, sir. I may say something like
Not
that.
PFS, response rates, because that's what is important for you in this patient now, because she's got lots of disease, huge liver met, which has progressed now, lung met, bone met, disease all over the place. So do you think response is important in this situation or not?
Yeah, very much important and
Very much
aggressive
important. Okay, so what's the likelihood of getting a response with exemestane and alpelisib?
Probably less 25-30%, sir.
25-30%. Okay, lovely. Sahu, your choice of treatment.
Yeah, here I will do NGS. I will.
Here you will do NGS. I've given you the result. I've given you the result. PIK3CA is positive.
Yeah, apart from PIK3, if the AKT pathway, nothing else is there.
Nothing else is positive in the AKT.
So then, if there is not there, I will go towards the TDM1 with the data is coming through. Otherwise,
TDM1, TDXD. You mean TDXD?
Sorry, TDXD. And if there is a mutation at the AKT pathway, then probably capivasertib or something can be discussed.
Sir, I'll be other way around.
Okay, what's the other way around?
Can I put a word?
Yeah, please, go ahead.
Sir, I may keep TDXD as the next line option, probably.
You'll keep TDXD as the next line. You're sticking to the label, that means. Okay, Chetan, your choice.
At this point, I would probably intervene with some kind of chemotherapy.
Okay, so capecitabine is
chemotherapy.
good?
Maybe weekly paclitaxel or something like that.
Excellent. So you're not happy with capecitabine?
No.
Why
would stick to... Sorry?
Why is it that you don't like capecitabine?
Well, there are multiple issues with capecitabine. The absorbability.
Tell me a couple of them.
So,
tell me a couple
first of all, the absorption of capecitabine is extremely variable. It changes with diet. Compliance of capecitabine is tricky.
Okay, so you don't like capecitabine.
So I don't like capecitabine.
Okay, excellent. Biswas, what is your choice of treatment?
So even though it's a PIK3 mutant, so after you see for last almost a year, so I don't know if it is because of TDXD. So even the Novartis doesn't give importance to the drug. None of our physicians, because everybody lands up in a problem with alpelisib and you don't get a response. So
I agree.
Be it a rashes, be it a diarrhea and sugars 600 plus. So I think the era is absolutely gone. So if my patient can afford, so definitely this is a candidate, a TDXD, and where I want some good amount of PFS, quality of life is going to happen with that. So any other thing not work.
Anything. So Novartis themselves are not promoting alpelisib anymore, but that's what Biswas says. So yes, but you have a point there. It is definitely one of the treatments of choice when somebody is PIK3CA mutant. So why do you like capivasertib, Sahu? There is a PIK3CA, mTOR, PTEN, AKT pathway mutation. You said you will use capivasertib. What is it that makes that very attractive for you?
If you look at the subset analysis again going through, and I will listen to you tomorrow how to look into that. So you find that there is a maximum benefit in the patient who have the pathway disruption and the mutations in that.
Correct.
That is the only reason which I want. Otherwise, for all comers, I'm a little skeptical. That's why I told the NGS really comes in at this point more than the initial part.
Okay, lovely. So you made a very important point. In that study, the Capitello study, half of all patients had some kind of a mutation, and the majority of that half were actually PIK3CA, a small sprinkling of PTEN and AKT. That was less than 10% of all patients. The other half, either the mutations were unknown or they were negative for the mutations. So That half all of the patients is from where you get your data, and the drug is approved only for patients who have a pathway mutation. It is not approved for patients who don't have mutation or all comers. That's just for us to understand. Again, for in this patient, I think what is important is good response rate, whether it is capital O, whether it is PIK3CA, alpelisib, or whether it's capecitabine. The response rates that likely to get in this patient ballpark is somewhere around 30%, which is not a great number. It's a bad number, but it's still not a great number. However, this patient was put on capecitabine and she progresses with new bone lesions in 3 months. Your next line of treatment, Bharat.
TDXT, sir. HER2 low, probably.
TDXT.
Sir, but now before a drug with the best response rate and the drug with the best PFS among all the available options that we have. TDXT, I think.
Okay, and your reason for putting this patient on TDXT is that this patient is plus positive. That's what you wanted to do.
HER2 low is there, so some sort of a HER2 expression is there. And of all the choices, I think the drug with the best response rate, disease stabilization, and PFS is TDXT. Sir.
Excellent. But this patient was germline BRCA positive. Germline BRCA positive.
Germline BRCA. Sir, I will have an option, but I think TDXT, I'm good enough with the PFS, probably better than any of the other options available. I still go ahead and put my TDXT and then
PFS
keep olaparib in the next line of treatment.
Keep olaparib in the next line. Ketan, would you like to use olaparib if this patient was germline BRCA positive, or would you stick to TDXT?
I would give weekly Paclitaxel.
You said Taxol? That's a good choice.
olaparib.
Okay, weekly Paclitaxel and maintain with olaparib. Nice choice. I agree that it's one of the valid choices.
I think if I have to use a PARP, I'll use it earlier rather than later. Point
Yes,
number
sir.
one. That's something. Because later
You
on,
will use
PARP,
it earlier.
Yeah.
You will use it earlier.
Yeah. Beyond 2 lines, you will see PARP
Again,
really
post-hoc.
not performing in breast cancer.
Again, post hoc unplanned subset analysis.
I agree.
Post hoc unplanned subset analysis.
I agree. But whatever data we have, the drug is
Excellent.
best used in the first line or maybe
PI
second,
first.
not beyond that. So
Yes.
that is my take on it. It is not a drug that is very
so
effective.
you want to use it early.
Yeah. And last
Okay,
point,
okay,
looking at
agreed.
the bulk of
So-
disease, if the bulk of disease very much, I would not be very much pushing for a PARP-like thing. I'll be pushing for a TDXD or a Pacli weekly, as Chetan spoke about.
Okay, super. So you will not push for PARP because the response rates are not good. Just for your information, Sahu, the response rates to a PARP inhibitor is about 60%, which is not very different from what you got with TDXT. But of course, different patients, different trials, different set of issues. But if you just want to know the response rate for a PARP inhibitor in patients based on the respective studies that were done with talazoparib and olaparib, the response rates are roughly around 60%. So it's not bad at all. But I agree with you that in this patient, I would be very tempted to do TDXT because of the way that study was done. And yeah, please, this was.
So, but
Go ahead.
in the later lines, PARP are actually a very notorious. And since I have extensively used in the olaparib generic trials about 60 odd patients, and there are quite a number of breast patients, none of them go beyond 3 months of responses. And in the later lines, lots of anemia issues, transfusion issues. And so this is not like the ovarian cancers, no? So breast cancers.
And sir, Olympiad also first line only had
I'm not saying you should not.
Olympiad is okay. Yeah.
Okay, there's nothing wrong in there. No, I'm just trying to tell you all the numbers, Bharat. I mean, when you have a
Our moderator is lost.
Yeah.
We'll just connect with Dr. Senthil. Just give us a minute, sir.
Anyways, Chirag is with us. He can start his next session.
I was just telling that
it's so boring.
our Hasin.
Yeah, I'm back. I don't know why you got that. Okay, so that's TDXT. So the next intuitive question about this is, what would you do if somebody had ultra low expression?
So sorry to interrupt, but
let's say
you need
this
to present your slides again. Your slides are not visible.
Again? Okay, I will stop share and then share it again.
Sure.
Is it okay now?
No,
Not visible, sir.
not visible.
It is not. I don't know why it's not visible. Anyway, never mind. We don't need the slides. That's fine. So, Sahu, what would you do if this patient had HER2 low, HER2 ultra low? Hello, can you hear me, or am I also lost?
Dr. Senthil, so even
Hello, hello.
not only ultra low, I have used even in a HER2 0, so triple negative breast cancer where I have lost all options.
We will come to HER2 0 in a moment.
And this patient had a beautiful response.
Hello.
Okay, yeah, Dr. Senthil, are you able to listen? Hear me? Yeah.
Yeah, come in.
So Destiny 06 had a subset which were ultra low. Destiny 06 had a subset which were ultra low, and the response rate and the oncological outcomes are similar to the ultra low. So I think there is a case if there is a ultra low as per the definition. That is something we need to define, and that is something we need to educate our pathologist. And if that fits into the criteria, I don't think that keeps us a TDXD does come into the picture in this subset of patients who are pre-exposed already. And the quantum of benefit appears to be similar as HER2 low. That's my take on it.
Excellent. So Sahu is absolutely right that there were about 150 patients in the DB06, which is a slightly earlier line of treatment, wherein, as he's saying, that the magnitude of benefit, at least in terms of delta for PFS, was the same, whether it is ultra low or whether it was low. It's about 5.5 months, 13 months versus 8 months. That's what was there in the study. So he's absolutely right. So Amol has said that there is no data for patients with HER2 0. Biswas, you wanted to use it in patients with HER2 0 also.
No. So there is a basket trial, and
where is the data from?
Daisy trial. So that showed a 30% response in a HER2 0.
Absolutely. So that showed a 30% response in patients with HER2 0. So then the question that begs us is, should we do HER2 at all? If HER2 0 is going to respond, HER2 ultra low is going to respond. 1 plus 2 plus is going to respond. 3 plus is also going to respond.
So 2028, so no HER2. 2028, there is no HER2.
Okay, Bharat, what is your thought on whether we should do HER2 at all, or all comers can?
Sir, Daisy is one of the things, but when you look into preclinical data, it did not show benefit. TDXC, sir, probably those patients has some degree of HER2 what sir is telling. The IST might have not picked up that thing. For me, 0, I will not use it now. I'm till now because sir, preclinical data is otherwise. But again, till we have a data of 0, I think we should not use it.
Because I had no choice about this patient who had a brain metastasis.
So as of now, we will not use it. Everybody is correct. So we will use it typically as per the label as of today, which is only for HER2 low. The label has not been extended for ultra low also. So we'll stick to the label as of today, both in terms of choice based on HER2 positivity and also in terms of the line of therapy, because DB06 did not need any chemotherapy exposure at all. DB04 needed at least 1 line of chemotherapy. That's why the numbers are also a little different, DB04 to DB06. So the earlier you're going to use your therapy, the outcome is going to be better. So Amol is right in a way that that you should not be using this drug in patients with HER2 negative disease, at least till we get more data. So why is it that we should do? Reason why we should do is, though Biswas is right, in that cohort of patients, there was a 35% response rate. The magnitude of benefit keeps changing depending upon the positivity. So for patients with HER2 0, the PFS is 4.5 months, hardly anything. For patients with low, it is about 13 months. For patients with HER2 positive disease, that's the 3 plus positive, the PFS is 29 months. So 4.5 versus 13 versus 29 is a huge difference. So based on that PFS benefit, we will really not go ahead and use it in patients with 0. So Sahu, let's come to some theory before we close. I think I've got 5 more minutes to go. Why is it that this is working so well? Yes, please.
Can I ask a question, Senthil?
Yes, please.
So I take you a step further.
Yes,
I take you one step further.
Yes.
So I have a patient
Please.
who was exhausted all chemo, virtually all hormone, and even PARP inhibitor, and one line of TDXD. And patient is fine at the moment. So she's hormone
Okay.
positive. So is there a data on
Okay.
TDXD re-challenge?
Okay, so let us ask two questions then, Bharat or Sahu. You can take that. One is TDXT re-challenge. The other is where do you place sacituzumab govitecan in the sequence?
Yeah.
Because
So
there is
for
data for
the
sacituzumab
yeah,
govitecan also.
for the sequencing, the govitecan has been used in more later lines. So if I have to sequence, I will probably use TDXD followed by sacituzumab. But with the point that ADC
Is there
followed by
data?
ADC,
Is there data, Sahu? Is there data? Yes.
no. I was coming to that.
Okay.
With that
Okay.
caveat
Okay.
that ADC followed by ADC are not going to do well. You have to remember that the trial did not have the ADC followed by ADC. So we have to keep that caveat.
Okay.
But if I have to sequence it, it will be TDXD followed by govitecan.
Okay, so TDXT followed by TDXT you would not do. If you're doing sacituzumab, you would do TDXT followed by sacituzumab. Again, there is some retrospective data, single institution data on challenge with sacituzumab after TDXT. There's hardly any activity for sacituzumab after TDXT use. The PFS that you see on individual patients is probably 2 months, 3 months, 4 months.
3 months.
That's about it. So it's not a great strategy to do. Yes, so it's not a great strategy to do. Very interesting, though the target is the same. Both of them are TROP2. It's just that the target that they're looking at, I mean, both of them are topoisomerase inhibitors. It's just that the target they're going to hit is different. But as long as the payload is going to hit the same target within the cell, it doesn't seem to be working. Very interesting data as far as TDXT and sacituzumab are concerned. So Sahu, before we end, why do you think it is working so well in low and ultra low and all of these things? What do you think is the mechanism? Last 2 minutes. So you can tell me the mechanism and then we
Yeah,
can
I think
close.
the bystander effect is showing here more than the target thing.
Okay.
So once the target is released,
Bystander effect.
That's what my little bit thinking is. I'm not expert in the basic science, but that's what I have read somewhere that probably would be a major cause of the responses.
Okay, Bharat, anything
Yes,
else in
sir.
addition to
Freely
bystander?
permeable through things, sir, bystander effect. It's easily permeable through membrane. So that should be the best reason to explain it. One cell, it can diffuse through surrounding cells.
Okay, so bystander effect is important. The other important thing that we think is that when you do a better technique, so one is the heterogeneity of expression of HER2 itself, which somebody brought up. I think, Bharat, you told me about the heterogeneity of HER2 expression. Some cells might be positive, some cells might be negative. So the cells that are positive are responsible to trigger that, effect. And then 3 is, again, a point that Sahu initially made. We are taught to look at positive and negative. So even when you look at patients with HER2 negativity, if you do a better technique, for example, if you do immunofluorescence, you're likely to pick up a lot of HER2 receptors. So heterogeneity, the way we are detecting HER2, our definition of HER2, gastric HER2 is different from colon HER2, is different from breast HER2, our definitions, and of course the bystander effect. So there are so many reasons why we think this drug seems to be working in patients who actually don't have the the expression of the receptor or very low expression of the receptor. So just to summarize, we've run out of time. So this is a drug that you surely should think about in patients who are HER2 positive or patients who have HER2 low. We are not extending it to ultra low and negative at this point in time based on the label that we have. At this point in time, it is after 1 line of chemotherapy, but DB06 is no lines of chemotherapy at all. We may see HER2 mutation on NGS as well. Okay, let me not take some time. There's a little trick there, HER2 mutation, depending upon the site of disease and so on. Let's not get into that now. And then the response rates are about 55%, which is vastly superior to all the choices that our panelists actually spoke about, whether it's weekly Taxol, whether it is alpelisib, exemestane, or any other drug where the response rates are roughly around 30% in this setting. So this is vastly superior. The PFS benefit is much more. The delta is 5 months, 13 versus 8 months. In terms of the hazard ratio, it's in the 0.60s. So in all ways, it seems to be superior to the standard choices that we have in this particular setting. Of course, there's no time to talk about the toxicity, so I will close here. Thank you, Sahu, for that opportunity, and I hope we learned something at the end of this session. Thank you.
Thank you, sir. Thank you.
Thank you, and we can go on the chat till I invite Dr. Chirag, sir, who is a senior medical oncologist and has been teaching us for quite some years now. We have been learning from him quite a lot, sir. Your thing on early TNBCs, and you have Dr. Amol, Dr. Vamsi, and Dr. Vijay as your panelists.
So thank you very much, Sahu. I hope I'm audible and my slides are visible.
Yeah, you are audible, and thank you for all who are still there, 170 odd still after 2 hours. Really speaks a volume of the moderator's skill who are all moderating today.
Great. So my panelists are Dr. Vijay Agrawal from Bangalore, Dr. Amol Okhade from Mumbai, and Vamshi from Hyderabad. And I could see all of them on my screen. So I'm going to discuss about the management of early triple negative breast cancer. And when we discuss triple negative breast cancer, we will not enter into the nitty-gritty of HER2 low and HER2 positive, HER2 ultra low at this point in time, because we are going to discuss early TNBCs. So we will begin with some general discussion on unanswered questions on early TNBC, and we will try to explore the answers from currently presented or published clinical trials. So earlier this year, ESMO has updated the guidelines of early breast cancer, and it has divided TNBC into clinical T1A or T1B, where primary surgery is being offered, and for all other, it is neoadjuvant therapy. And I think it is an overkill for some of the patient, and we will be discussing that with my panelist. To expand on this algorithm, we have something like this. So we do GBRCA testing in all patients with early TNBC. Now, if it is clinically T1A or T1B, surgery followed by further treatment decision. For T1A, we may withhold all systemic chemotherapy. T1B, it may be 6 to 8 cycles of systemic therapy. And for more than T1B, it is 6 to 8 cycles of systemic chemotherapy again. And not sure whether carboplatin is going to be any helpful over here or not. And for anything less than CT2N0, that is T1CN0 to be precise, it is 6 to 8 cycles of taxane with carboplatin, followed by AC. So immunotherapy is not written over here. And anything more than or equal to CT2 or not plus, it is chemotherapy with immunotherapy, followed by surgery and then further decisions. So what we will discuss today is about neoadjuvant as adjuvant therapy. This complicated algorithm has been simplified in a publication of educational book of ESCO in the last year. Stage 1, less than 1.5 centimeter, surgery as the first intervention, followed by adjuvant chemotherapy, and the adjuvant chemotherapy could be something like TC rather than combination of taxane and anthracycline. While for 1.5 to 2 centimeters, neoadjuvant dose dense, AC followed by taxane, and carboplatin is not mentioned over here. So these are some of the points which we will be discussing. And if there is PCR, no systemic therapy. If there is residual disease, capecitabine or olaparib, as the case may be. And for stages 2 and 3, neoadjuvant taxane carboplatin with dose dense anthracycline, cyclophosphamide, and pembrolizumab, and then further decision as per whether the PCR is there or not. So maybe Amol, I can ask you that what is your cutoff in offering neoadjuvant chemotherapy or not? Is it 1 centimeter, 1.5 centimeter, or 2 centimeters for TNBC?
If it is node negative, then generally I am comfortable if it is up to 2 centimeter.
Yeah. We are talking about negative only.
So node negative up to 2 centimeter, I will consider for upfront surgery, and more than 2 centimeter, I will consider for neoadjuvant. So most of the guidelines agree to that. There is only contrast between ESMO and ASCO about the 15 millimeter cutoff, 15 millimeter, 20 millimeter, there is some contrast. But otherwise, generally in our practice, up to T1, we are all comfortable.
Right. Vamshi, what about you?
I agree, sir.
Great.
I would be similar. Centimeter, I'm comfortable. I mean, sometimes, on a scan, it showed 2.2, it turns out to be 1.8 on final pathology. So, 2 is a general cutoff. I'm okay with it.
And Vijay, any patient between 1 and 2 centimeter, you will ever offer neoadjuvant therapy? No,
Depends on what the patient wants, really. I mean, above 1.5 centimeter, I do discuss neoadjuvant chemotherapy with them.
Great. So above 1.5 centimeter, when you discuss about neoadjuvant therapy, and if you and your patient agree, which chemotherapy you will be offering to these patients?
I always use a combination of anthracycline and taxanes. So dosed in acipacline.
And what about carboplatin?
I have not used carboplatin unless there's a BRCA positive or unless I'm adding immunotherapy.
So that is interesting. We will discuss that point sometime later in this discussion. So the question is, do all T1C need neoadjuvant chemotherapy? And our panelists said that most of them do not need neoadjuvant chemotherapy. We are all okay with upfront surgery followed by adjuvant chemotherapy. Do all T1B and T1C N0, when we are talking about adjuvant therapy, Vijay, do you give 8 cycles of chemotherapy or fewer chemotherapy is okay with you?
Now, if the patient is fit and otherwise well, because most of them, these patients tend to be younger patients, fitter patients, I tend to give the full 8 cycles.
Right. And you will combine taxane as well as anthracycline combination, right?
Correct.
Right. Amol, will you give platinum
Yes,
as
sir.
adjuvant therapy for T1 N0?
For platinum for T1 N0, I'll probably will avoid. I will end up giving anthracyclines and taxanes for T1 N0 adjuvant.
Okay. And Amol, there is data of SYS, UCC and some other trials about maintenance capecitabine beyond adjuvant therapy. So, which are the patients where you will be giving maintenance capecitabine, or you will not give at all?
I normally give it
So
if
the maintenance.
Sorry.
Yeah, please.
Yes, Amol.
Please go ahead.
No, I think you were asking
So-
me. Please, Swamshi, go ahead. Yes.
So for maintenance capecitabine is only if there is a residual disease post neoadjuvant. So post adjuvant, when you are
So there is
assuming
some
that
data.
adjuvant,
There is some data of
we are assuming
that.
that the patient is upfront operated because it is T1 N0. In
Right.
that situation, there is no role of any adjuvant capecitabine.
Absolutely,
If the
perfect.
patient
So
is,
that's the point. That's the point which I wanted to make. And Vamshi, I think you will agree with that, right? No platinum, no capecitabine.
Yeah, I agreed. The benefit of carboplatin in terms of OS has only been seen when you use it in a neoadjuvant. Now, I kind of disagree with Vijay when about the BRCA, because the BRCA and platinum data is all over the place. There's no clear one trial which says that the benefits, there's mixed data on it. So I am not very keen on using carboplatin because it does increase the toxicity. Regarding your question on whether for T1, would you use both anthra and taxane? That's what I routinely do. And I would be using dose dense like he has said.
Perfect. So we'll discuss about elderly patients in the next slide. But if anything T2 or larger and N1 or larger, Vamshi, will you use platinum always or not in the adjuvant therapy?
So like I said, platinum is not something that I'm routinely using. Only I give it when I'm giving a neoadjuvant. Because there's no right answer why you should or shouldn't do it, but the data is a bit mixed. In adjuvant, I don't give it.
Wonderful. So Amol, will you ever give platinum in any of the adjuvant therapy, larger tumor, node positive or whatever?
so for whatever reason that the patient has not been received neoadjuvant therapy and came to me post-operatively, and he has a high-risk disease, and in that situation, I will offer platinum based upon the accumulation of the data that the platinum does has a role. And unfortunately, this patient has not received neoadjuvant therapy, not received neoadjuvant immunotherapy. So
Right.
in that situation, I will offer the platinum.
Right. So the patient who qualifies for platinum based neoadjuvant therapy and miss to give neoadjuvant therapy, we will make it up in the adjuvant therapy, right? So Amal,
Yes.
adjuvant immunotherapy, any patient, any data?
So there is a trial of adjuvant atezo, which has the patient has not received neoadjuvant immunotherapy, and that situation, the trial is negative. So if the patient has not received neoadjuvant IO, then giving only adjuvant IO, as of today, there is no data.
Absolutely. So this is the trial you are talking about, right?
No, there is Alexandria trial. Alexandria is for only adjuvant.
Yeah, correct. So this is the negative trial, and this trial was stopped for futility at the median follow-up of 25 months. So no adjuvant, only immunotherapy. So that's the point. So Vijay, what about elderly patient?
Yeah, so elderly patient is a bit tricky. Again, depends upon the size. If I feel that, say, a lot of these patients nowadays, we are crossing 75, 80 years of age.
Right.
And even with a slightly larger tumor, I tend to, as long as they're node negative, I tend to go for upfront surgery rather than induction chemotherapy or neoadjuvant chemotherapy. That is one thing. And the second thing is that I may do only a taxane-only chemotherapy rather than a combination of anthracycline and taxane in the elderly subgroup of patients. The role of platinum, I'm uncertain in elderly patients because of added toxicity. The role of immunotherapy, see the data for the Keynote 522 was both for combination of anthracyclines and taxanes. And if I'm omitting anthracyclines, I'm not sure immunotherapy will add that much more benefit when I'm combining with only taxanes. So that's the kind of approach I take. I go for more upfront surgeries if I can, and use taxanes only if I'm concerned about anthracycline.
So there is no good one answer, but it depends on the situation and comorbidity index. So Vamshi, if the patient is 73 years, which is not very old, not very young, 78 kilo, which is not thin and lean, which is not obese as well, well-controlled hypertension, diabetes, and 2 episodes of rapidly improving neurological deficits in last 5 years. So some sort of comorbidity and good performance status. Patient has tumor size of, let us say, 2.8 centimeter and clinically node negative. So Vamshi, how will you approach this patient?
So these sort of patients, I will go with a stepwise approach. I would probably start off with the taxanes. I will see how the patient is responding. For 73, I would not really plan for giving anthracyclines. I would give 6 cycles of taxane here. I would go for surgery. I'll see how it is. And then I will decide how it is going.
So I think, as Vijay just said, that if it is T2 and 0 or earlier disease, one may seriously think of offering surgery first, because that is the curative treatment, and whatever adjuvant you have to give, you can carry on later on. So Amshi, will you do that in some patients?
So for me, the benefit of giving taxane upfront is if I do find that there is no patch here, I would actually add the capecitabine at the end of it, because that would help in such a case where I cannot give anthracyclines. At least I'll have some reason to give a capecitabine. So that's my logic of giving it. And again, there's never going to be a trial on this. It's going to be just our understanding and how we go about it.
Correct. So let us see what the trials say about Lancet Oncology 2012 was the initial guideline, updated in Lancet Oncology 2021, and not sure whether it has been further updated. So for last 3 years, these are the guidelines for elderly patient with breast cancer. So for neoadjuvant chemotherapy, as you rightly said, Vamshi, systemic therapy similar to younger women. For fit older women, for less fit older patients are best served by surgery upfront. So fit and less fit is always a relative term, and that we take the decision in our clinic when the patient is in front of you. Sequential regimen with anthracycline and taxane can be considered in principle because of aggressive phenotype. But addition of platinum compounds has poor uptake in practice even in younger patients. So this is an old guideline. Nowadays, our uptake is quite good in neoadjuvant therapy. So Amol, anthracycline taxane combination or only taxane, and whether you will give platinum or not. Before that, you will give neoadjuvant or not?
So I will individualize this. I will have a geriatric assessment for that particular patient, because age is just a number. Some of the elderly patients may be fit, some of the elderly patients may not be fit. So geriatric assessment has to be done, and based upon that, the decision should be taken. For smaller tumors, I will tend to relax the 2 centimeter cutoff in an elderly patient and probably go for upfront surgery. But for a heavy disease burden, node positive, I will consider neoadjuvant therapy if the patient is fit. And when I consider for neoadjuvant therapy, of course, I will use the pembrolizumab-based immuno-based regimen, the keynote regimen in which it is given after discussing with the patient.
Right. So we don't have the data in the geriatric population for neoadjuvant immunotherapy, but you will extrapolate from the trial, right?
Yes, that is the important point, that we have to see that most of these trials, the representation of the true elderly population above 80 is very less. So all we have to use is our clinical judgment for that particular patient based upon the geriatric assessment and how much confidence we have thinking that the patient will be able to take the therapy.
So HER2 negative adjuvant chemotherapy, the guidelines say that duration of chemotherapy anything beyond 3 months is an important risk factor for the occurrence of serious side effects. Standard regimen includes 4 cycles of either TC or AC, or maybe weekly paclitaxel, which is level 4 evidence. Older patient with high-risk disease can be considered for sequential regimen if the patients are fit enough. And dose-dense regimen should not be used in elderly population. So Amol, you agree with that? Dose-dense should not be used in elderly population?
No, I don't use dose dense in elderly population, especially when you talk about elderly population, you talk about elderly Indian population. And it is very difficult for them to tolerate dose dense because there are multiple factors, not only just their own factors, but the factor about social support and other things also. So I don't use dose dense in the elderly population.
Right. The same thing in this table as well. So majority of our patients are qualifying for neoadjuvant chemotherapy, and we now offer neoadjuvant chemotherapy to all the patients. And Amol, what is the role of platinum in neoadjuvant therapy?
So if you are offering neoadjuvant immunotherapy and if you are giving keynote-based regimen, then the platinum is part of it. So technically, we give it to all those who are able to take immunotherapy. And suppose our patients, because of cost issue, are not able to take immunotherapy, then I make sure that the platinum is part of the treatment plan, either neoadjuvant or adjuvant, based upon, because if the tumor burden is high and patient is high risk TNBC.
So we have the data of bevacizumab in JEPAR 6-2 trial and PARP inhibitor veliparib in brightness trial. But we know that these drugs are not going to work. And Vamshi, you will never use these drugs, right, in neoadjuvant therapy?
As of today, no. There was never any good data for Bev in breast. I don't think there's any good data. The whole brightness actually showed that the benefit was because of the chemo and the carbo, not actually because of the veliparib. So I don't think so. Any of these two I'll use anywhere.
So immune checkpoint inhibitors, Vamshi, you will sparingly use or always use, or you will want to use in all affording patients?
I'm sorry, I didn't get it. You were asking me about immunotherapy.
Immunotherapy, yeah.
Yes, immunotherapy, certainly. If it's a stage 2, stage 3 disease, neoadjuvant, I am offering for all TNBCs who can afford and who are, I mean, I do offer it and discuss it with all the patients because the Pembro data is pretty good. Adjuvant, I'm not a big fan of. I don't think adjuvant alone we have good enough data. We have multiple negative trials, but when I'm giving a neoadjuvant, I do use it.
Right. So ISPY 2 was the initial trial where the PCR rate increased from 20% to 60%. Neotrip PDL1 was a negative trial. Atezo chemotherapy followed by surgery versus placebo chemotherapy. No change in the PCR rate. And we don't have long-term outcome of this trial, but this was largely a negative trial. And this is a good trial. And now in last SABCS, we had the 5 years update of this trial. Carbopacli followed by AC or EC and pembrolizumab or placebo followed by surgery. And if you look at the PCR rate, the primary endpoint, the increase was 14%, and PDL1 positive, the difference was 14%, negative, the difference was 15% actually. So good difference, good delta between the PCR of both the trials. And this is not sufficient for us to take up immune checkpoint inhibitor in our practice. We need long-term outcome data. So at the end of 5 years, the absolute difference in the entire population was 9%, which is significant. And for the patient who achieved PCR, still the difference was 4%. And for the patient who did not have any PCR, the difference was 10% in event-free survival at the end of 5 years. Now, someone can tell me that event-free survival is not sufficient. We need overall survival. So, Vijay, do you think that EFS for TNBC at the end of 5 years is not a very good endpoint, and you still will want to have a look at overall survival?
See, the question, currently we are all using it, and I think everyone in the panel is kind of in agreement that all our patients get immunotherapy if they can, if they're eligible for it, fit for it, and can afford it. The question arises that in the future, let us say in another, say, 4 or 5 years' time, if the overall survival shows no significant benefit, the question is, what do we do at that point in time? So currently, in the absence of the overall survival data, I think we're quite happy with an absolute difference of 9%. 9% in the immunotherapy arm, and I'm quite happy to offer it. So I don't think so I'll be waiting for an OS data to offer immunotherapy to our patients, and we're currently doing it. What I don't know is that if the OS turned out to be negative, then would they withdraw the indication or not?
Right.
And they've done that for TESO in metastatic diseases and things like that. So
Amol, for the indication like TNBC, if this is data at the end of 5 years, do you expect that the OS will not show up in future?
I think the OS will likely to be positive.
Yeah.
And it will be highly surprised that if the OS turns out to be negative, unless they have taken a very stringent alpha value, which I don't think so they have, the p value, which I don't think so they have taken. So it should come out.
So sometimes we feel that with Keynote 522 data, all our questions have been answered. But more and more questions are raised after Keynote 522 trial. And some of these questions are whether platinum, if neoadjuvant immunochemotherapy is used, whether ICI only in neoadjuvant, whether ICI can be omitted after surgery if there is PCR, whether only chemotherapy as neoadjuvant treatment and immune checkpoint inhibitor for non-PCR, and the role of capecitabine in all these scenarios. So we will look at the data on all these questions one by one, and then I will ask for the opinion of all the panelists. How much time do we have? We have 10 minutes or less than that?
So 5 minutes, 5 to 6 minutes.
So we will really hurry up. Platinum with ICI. So I am patient 031 is a positive trial where atezo chemotherapy versus placebo chemotherapy, and there was no platinum in the chemotherapy over here, and there was good difference in the PCR rate, as well as long-term outcome also was better. It was statistically not significant, but this is relatively early data. And Vamshi, do you think that in this trial, lack of platinum or addition of platinum would have made any difference?
See, I think first of all, using a PCR as an endpoint is not enough now for a ICI trial. You need a PFS at the least. That is exactly what Pembro has done, and you need to match that as a benchmark. So that's number one. Number two, platinums I think should be added in all neoadjuvant therapy, as I think Dr. Sindel has pointed out in the chat as well. But it should be added. So atezo alone, how much benefit it is going to give in breast, I really don't know. When you have a drug which has not worked in the metastatic setting, you don't really expect it to work in the early setting as well. So, the drugs are different. I don't think we can call it all down to trial design. You have to use platinums, and I think Pembro has done well. So you need an IDFS or an OS or PFS. A PAT-CR doesn't cut it anymore.
So we need the data at longer term, and if that shows positive, then we may question whether platinum is really required or not. Right? Vamshi?
Yeah, I want some survival data to be positive. And that should be positive overall. You can't have a subset and say that, okay, this little subset benefited on a post-hoc analysis. In breast, I don't think that should be the approach.
So, immunotherapy only as neoadjuvant therapy had been tried in JIPAR Neo study, a small study, durvalumab running period of 1 cycle followed by nab-paclitaxel durvalumab, again no platinum, and EC and durvalumab. So there was a not very significant, modest difference in the PCR rate. And if you look at all the long-term outcome, and when I say long-term, we have the outcome of up to 3 years. In IDFS, DDFS, as well as overall survival, there was a good difference. And this is published in 2022. And in the conclusion, it was written that durvalumab added to neoadjuvant chemotherapy and TNBC significantly improved the survival despite modest PCR increase and no adjuvant component of durvalumab. So, even though looking at Keynote 522, we feel that platinum is important and continuing immunotherapy beyond surgery is important. It may not be the case. There are several such trials. I have selected just one. Amol, your opinion on
See,
this point?
ideally, yes. Ideally, we should have a trial in which neoadjuvant IO is compared with perioperative, that is neoadjuvant adjuvant IO. But that kind of a trial in which is not going to happen, and what we call as a missing third arm of the trial syndrome is always going to be there. So
Right.
now the pembrolizumab data is so robust that I'm not so sure whether any of us are looking at any additional options. What we are looking at is maybe, so neoadjuvant IO is definite. Whether the adjuvant IO for everybody or not, based upon the PC, the RCB 0, can you avoid that? Or for RCB 2 or 3, can you do something different? That is the question that we are looking at.
Perfect.
Now, we are not looking at whether neoadjuvant versus perioperative, because that trial cannot take place at all.
Perfect. So unfortunately, we have several trials, but small trials, and not enough long-term data on this trial to answer some of these questions. So if the patient was given chemotherapy as neoadjuvant therapy and no PCR, this is the trial, A-BRAVE trial, where adjuvant avelumab versus observation was given. And in this trial, you can see that adjuvant capecitabine was given in almost 1/4 or maybe 1/5 of the patient on both the arms. And if you look at the long-term outcome, and when I say long-term, 3-year data we have right now. So in 3-year DFS, there was a difference of 5.1%. 3-year overall survival, the difference of 8.5%. And 3-year DDFS, 7.5%. If you look at only neoadjuvant patients, this is the upper part of the table is all patients. Only neoadjuvant is 195 plus 188 patients, and there the difference in 3-year DFS is 6.2%. So, Vijay, this is good enough, or you still need some more data?
I think this will need more confirmation. I mean, the primary endpoint of this study was a PFS and not OS, and that was negative.
Exactly.
And even if you look at in the neoadjuvant patients, the patient numbers are not. I mean, to get an OS data with such small patient numbers in breast cancer is, I think, one needs more validation from either the same drug in a different setting or a different drug in the adjuvant setting. See, the science behind the efficacy of immune checkpoint inhibitors in the neoadjuvant and adjuvants is completely different. So it seems like there needs to be a tumor microenvironment for immunotherapy to be effective, and you can get that only in the neoadjuvant setting and not so much in the adjuvant setting. And hence the kind of difference that we are seeing in terms of the efficacy and outcome. So I think one single study, avelumab, even though they have the right target population, patients without a complete pathological response rates, I think needs more validation, primarily because the primary endpoint was negative.
So as I just said, there are multiple small trials, and we need to have
That's the
long-term
last minute.
trials.
Last
Yes, Sabu, just last maybe 40 seconds. Neoadjuvant datopotamab deruxtecan, and we have some data, but the data is evolving. Then there is a trial of nivolumab with chemotherapy. Nivolumab followed by nivolumab chemotherapy versus nivolumab chemotherapy followed by nivolumab. And there also we have some data. So everything is evolving. This is my last slide. The same questions I have asked again, and not sure we have answered some or all of these questions or not. Maybe last comment from all my panelists, and then we can close the session. Starting from Amol. Anything?
So yes,
last moment, any message you want to give to the audience?
So for any high-risk TNBC, platinum is necessary, irrespective of whether you use IO or don't use IO. If you're using IO, that is well and good. There is no point in giving only adjuvant IO if you're not giving neoadjuvant IO. And of course, if the platinum can be given adjuvant also. And what we like to see in future is that those patients who are achieving PCR, can we omit or reduce the duration of the adjuvant IO? And for those patients who are not receiving PCR, is there anything to escalate? So these are the questions for future. And capecitabine, of course, is a good drug, especially if there is residual disease and we are not using the IO, or if you're using IO and if there is a residual PCR, one can add capecitabine.
Okay, Vijay, anything remaining from what Amal said?
No, I mean, my only question I'm going to leave the audience with a thought is that we are now using chemoimmuno for the vast majority of the patients in the adjuvant setting. Now, the keynote study looked at continuing with adjuvant pembrolizumab, which we know that may not be very effective because the NEVO study was negative, the DITVA study was negative, and the Evolumab study was negative. So the question is, are we now denying the patients, if they don't get a complete pathological response, are we denying them olaparib and capecitabine just because we want to continue immunotherapy, or should we switch from immunotherapy to those drugs, or give both of them? I mean, it's just a thought I'm leaving everybody with.
So Vamshi, and then
we can give both. We can give both if there is a residual disease. We can definitely add capecitabine to the IO, or if the patient is BRCA mutated, then we can add olaparib.
So in practical terms, we're doing that.
We're doing that. Evolving
we're
data.
doing that, but there's no data for it. That's the thing.
Yeah.
Vamshi, your comment, and then we can close the session. Vamshi, you are muted.
I think we have lost Vamshi.
Well, yeah, he is muted. Anyway, Sahu, over to you. Thank you very much. Thanks to all the panelists, and thanks to the organizer for giving the opportunity for this wonderful discussion. Thank you very much.
Yeah, I think we will move on to the last panel, and we can take the questions which are open, because these are the open questions which we will going to get the answers definitely by 2028. Right, Amol? So everything what you need to know, what is in the unknown, you can just peep into the crystal ball you have and then tell us the answers. So you have your panelists, I think so, Dr. Sandil, and you have Vijay, and you have Nitesh.
Nitesh. It should be there. Otherwise, you become the panelist.
No, I think you can start off with, you have two lovely panelists. Till Tarun, you can just catch up with Nitesh.
I'm just calling Dr. Nitesh.
Please start on.
So we are going to talk about breast cancer in 2028. And this is basically an attempt for us to look into the future and speculate what may happen in the near future. And let us understand 4 years is a long period in breast cancer. If you think about 2020, there were no HER2 ultra low or HER2 low, and there was no much data for susceptible gluten. So there were a lot of things were not there 4 years back. So let us see what can be there after 4 years. I have no conflict of interest to declare. I have a crystal ball, and only problem is that it is slightly politically oriented. So when I ask him what is going to happen in future, it ends up with this slide, Daro mat aayega to Modi hai. But of course, it is showing still Rahul's photo. So it is confused. And before Sahu decides to run away, Dr. Sahu decides to run away with the crystal ball, let us quickly move to the clinical case. And so two of my panelists on a busy Monday morning, your secretary rushes to your OPD with a young, tall, beautiful lady, and you get stunned to see her. And your first thought is that you have seen her somewhere. And as you are stretching your gray matter, your secretary says, sir, she is the top model of the country. You must have seen her on the big advertisement billboards all over the city. You actually get relieved to know this. Don't ask me why. She has actually come to you for a second opinion. You go through your file, you categorically ignored the name of the colleague you have treated her previously, but that is the first thing that you try to see. And you note that she had only a 17 mm lump, IDC grade 2, ERPR positive, HER2 3+, Cas67 15%, BRCA1 2 negative, PET was done earlier, and she has refused for chemotherapy. Your colleague had given her a subcutaneous double anti-HER2 preparation at home every 3 weeks. And probably now you come to know why your colleague was absent for weekend conferences. Her repeat PET scan at the end of 4 cycles is CR. There is no lump anywhere seen, no disease anywhere. Now she looks to you and asks, like a model, that I don't want to undergo any kind of surgery on my breast. My career will be over with that. So what do you think? Can we avoid surgery in any form, including BCS as first option in 2024? Dr. Vijay, your thoughts on this?
Yeah, so in 2024, I don't think so we can avoid surgery at this point in time.
Okay. What about 2028? Do you think in 4 or 5 years' time, we will have data to avoid surgery in this kind of a patient who has a complete radiological response and there is no tumor and she wants to avoid surgery?
Yeah, the data is still evolving. I mean, there are other techniques like liquid biopsies, looking at minimal residual disease by measuring ctDNA.
So I want to. So do you think it will happen by 2028, or it will be much beyond that, or probably will never happen?
It might be beyond. I think it will happen at some point in time. I think the data for colorectal is already evolving quite nicely. I think breast will just catch up very quickly on that, because I mean, if people want to avoid surgery, I think the data will eventually catch up to prove or disprove it one way or the other. So we'll know in a few years' time whether we can use liquid biopsies or not. So the question is like is crystal ball. I don't know which way the data will go. But all I can tell you is that in 2024, I don't think so avoiding surgery is a good idea.
So what about Dr. Nitesh? If you're there, what's your thought? Can you avoid surgery now? And do you think after 4 or 5 years?
Please stick to
He's not there.
And Dr. Vijay.
Okay. So Dr. Senthil, so what is your thought? Can you avoid surgery in any form for this patient as a first option in 2024? Yes or no?
No, surgery.
No.
We will do
surgery has to be
surgery.
done.
We can't avoid surgery in 2024. Correct.
What about 2028, sir? Do you think in 4 or 5 years' time there will be such data? And I'd like to show you some data which is already published in Lancet. And what do you think in 4 or 5 years' time this will likely to happen, or as Dr. Vijay said that probably a longer time will be required, but it will happen, or do you think it will never happen?
It will happen, but whether it will happen in 2028 is a big question. But it will certainly happen at some point in time. We will be able to choose our patients better. I know there's already some data, but it's not very convincing at this point in time.
Yeah. So as of today, of course, the answer is no, but wait and watch is coming up for rectum, maybe it coming for colon. So why not breast? We have better drugs, more target-specific breast drugs, and if the tumor disappears, why we cannot avoid surgery? And that is the question that was asked by and published in this particular phase 2 trial in Lancet Oncology. And it was, I think, in 2022, and it is MD Anderson's trial, multicentric trial in US. And what they did is that they selected, of course, early stage breast cancer patients, and all they did was they proved the diagnosis by a minimal invasive biopsy. They gave neoadjuvant therapy, and after that, they have core biopsies to prove that there is a PCR, and if there is PCR, they avoid surgery. And if you see, it was a small trial. Almost 58 patients were taken, and 50 patients enrolled. They have a predominantly node-negative population, and if you see, they have both HER2 positive as well as triple negative patients. And if you see the results, and they are better given here, that at a median follow-up 26.4 months, the 31 patients who had pathological complete response after vacuum-assisted core biopsies, after neoadjuvant therapy, there was no recurrence seen. And if you see this particular curve, now I want both of you to have a look at it, and everybody to have a look at this. It is a horizontal line. So imagine if this curve is for a new ADC, everyone will say, oh, the ADC is working excellent. But just because it is for a trial in which surgery is avoided, probably we are not very convinced with it. But there is a data, and there is a lot of trials coming up. There is a trial coming in Germany. There is a trial coming in Netherlands. There is a trial coming in France and UK. And if you see the number of patients, in fact, some of the trials have 525, 600 patients. So this is going to come up in future. So what do you think? I just wanted to, this is the existing data that is there. There is only one published trial, but it is a very, so Dr. Senthil, do you have any other data that you think of? And what is your closing remarks that do you think in the future is going to occur? Because some of the patients may like to avoid surgery and associated morbidity, probably for cosmetic reasons. But of course, we don't know whether OS will get affected by that, whether these patients will require longer adjuvant therapy, like the case patient. She may require probably longer anti-HER2 drugs as a maintenance therapy if she wants to avoid surgery. So we don't know these answers. So your thoughts on this, Dr. Vijay?
So I don't think longer therapy is the answer. I think the standard 1-year therapy is what patients will get. I think closer follow-up would definitely be required. But honestly, I just don't know whether we can avoid surgery completely. And I think all of these trials will, once the data materialize, see, the trial that you showed, the small trial of 50-odd patients with the 2-year follow-up is grossly inadequate to make any conclusions. I mean, 2 years is too short a period for any adjuvant breast to be followed up for. So I think a straight flat line of 100% on patients who've got complete pathological response is what we'd expect whether we give surgery or not. I mean, I think closer follow-up and standard treatment for chemotherapy or targeted therapy is what we'd do.
So Amol, can I make a point? Yes. I think
yes, sir. First, let me ask you: are you flattered by this curve? If it is a
no,
ADC
I'll
curve,
tell you why the curve is so flat.
Okay.
So I'm not flattered, but I'll tell you why it is flat. So I think as medical oncologists, we are not very familiar with this term vacuum biopsy. So a vacuum biopsy is getting a big piece of tissue from the tumor. Okay, it is not like your core biopsy.
Yes.
So what they have done in this study is that they've done multiple vacuum biopsies in the name of sampling to make sure that there is PCR.
Yes.
So that is as much as a
9 to 10.
lumpectomy. Okay, it is just a lumpectomy with positive margins, if you want to say that. So so in theory, you're right that these patients avoided surgery, but in reality, was the multiple vacuum biopsy nearly as good as surgery? The answer is yes. So the surgeon's point here is that it is much easier to do a nice simple lumpectomy for this patient with a T1A tumor rather than poke this lady 10 times with all the problems that are likely to happen with doing multiple biopsies. So I'm not very excited looking at that straight line curve. I would have been excited if they didn't do a biopsy at all. Right? Not after doing a biopsy, taking most of the tumor out and then saying that this didn't come back. So there's a lot of catches there as to why that curve is as good as what it looks like. So I'm not flattered, but I know why it's flat. So that's the way I look at it.
So let us understand. Yes, sir. Please, sir. Dr. Sham, sir.
Right. So I think it's quite feasible once we have the ability to detect the minimal residual disease. For example, if you have a HER2 positive tumor, I mean, if you have the NGS available and then you're able to do deep sequencing for follow-up after surgery, after chemotherapy and the targeted drugs, by CAP sequencing, if you can figure out that the HER2 has become negative, which is the driver mutation in this individual, so then I think that is where you'll be able to avoid surgery. So
you will say that you do
Amol, can I make a point? No.
So if we are talking about ctDNA,
no, I don't think.
Yeah, deep sequencing, not
I
just
don't think
ctDNA.
ctDNA is the answer. No, I don't think ctDNA is the answer. The answer is to be able to predict who will get a PCR with just dual anti-HER2 therapy. You may pick up ctDNA. How are you sure that the disease is in the breast and not sitting in the liver? So I think that's not the question.
Hold on.
If you want to avoid surgery, you want to first be sure.
The HER2, whatever driver mutation is there, is likely to be present at all sites of the disease. So if it was at a particular, if you have the VAF at a particular level, and then post-therapy, you have a complete radiological remission, and then on CAP sequencing for that driver mutation, or it could be not only just one gene, it could be like 16, 15, 17 genes, which you could have some kind of an algorithm. We're talking about 2028. We're not talking today. So, if you have an algorithm.
Let me interrupt. Of course, we have subsequent slides to talk about whether can you have a better test, as Dr. Senthil is saying, to predict that which patients will get a PCR. And as Dr. Sham sir is saying, that can we have some de-sequencing? So we will discuss in that subsequent slides. I'm coming to that. So as of today, everybody is agreeing that we cannot avoid surgery. In future, we may, provided we are sure that there is no disease either radiologically as well as some additional test. So the question comes is that the patient is well read, she's the top model, she comes and asks you, Doctor, will HER2-DX help me in saving myself from surgery? So what is your answer, Dr. Vijay? HER2-DX, the additional test done, and will that additional test help her in 2024 or in 2028 to avoid surgery? Yes, no, maybe, or we don't know at present. Dr. Vijay.
Currently, definitely no. Maybe in the future, once the data develops, I don't know. We've not been doing HER2-DX. Maybe in the future, yes, but not now.
Senthil sir, what's your opinion? HER2-DX. She's telling that I have done HER2-DX, and in HER2-DX, for everybody's benefit, it is a 27 gene expression test. It will give you 2 scores. One score which will predict about the PCR probability. One score will predict about the low risk versus high risk. So suppose this lady does an HER2-DX and at the baseline, and there was a high probability of PCR and low probability for relapse. That means she's a low risk for relapse and high risk for PCR. Can we use that test to avoid surgery? Senthil sir.
So, Amol, the answer is yes and no. Not at this point in time again, but later probably yes. But we all know that a PCR that is achieved in a patient with a 1 centimeter tumor is different from a PCR that is achieved in a 5 centimeter tumor. You may achieve PCR in both these ladies, but the probability of relapse is higher in a patient with a 5 centimeter tumor even after you get a PCR. So can you extrapolate this to avoiding surgery just because you get a PCR? The answer is no. It will tell you that the prognosis is good. So if you did a HER2-DX on a 1 centimeter tumor and then came back to me and said that you just don't need too much of therapy, you're going to get PCR and the risk score is low, then I may be very tempted to tell that lady, okay, in the future, I'm talking about 2028, I may be ready to say, okay, avoid surgery. But if the same day had T2N1 and then they came with a PCR score like this and they asked me, can I avoid surgery? The answer will be no, because the relapse rate is higher in that situation compared to what you might get in a patient with a 1 centimeter tumor. And this data is already there. Whether you can add the ctDNA post-treatment as a third variable to it, I think we just don't have. Maybe yes, may not be, but that's the way we will take it forward.
So let me share about the latest presentation about the HER2-DX, and in which what they have done is they have done an individual patient meta-analysis of 7 cohorts of the previous trials. All these are all trials which have done before. It has randomized controlled trials and single-arm trials, observational studies, and they try to see whether there is a correlation between the trial results and the HER2-DX. And what they found is there is a very nice correlation between the HER2-DX low risk versus high risk, as well as whether you will get the PCR versus you will not get the PCR. So this was presented in this ESMO 2024, and it is an individual patient level meta-analysis showing that HER2-DX score is associated with survival outcomes as a continuous score and as a risk group. And probably we can predict in an HER2-positive patient using this score whether the likelihood of getting a PCR and likelihood of getting a relapse, and maybe we can use for de-escalation or escalation. Again, whether we can avoid surgery based upon this score is a different discussion, but the more important discussion is, can we de-escalate the anti-HER2 drugs, or can you escalate anti-HER2 drugs based upon this? And that probably is the future. And again, I always ask, what about the prospective validation? So when this paper was published in, I think, 2022 San Antonio, I'd asked this particular question. And Alex Pratt is the main man behind this particular test. He is probably devised it, or he is a part of the owner. So what answer he gave is, for a prospective validation, in the clinically low risk, it would require more than 6,000 patients, not feasible. And remember that we changed practice and use Adjuvant TH based upon a trial of 400 patients. So prospective validation probably is not going to occur, but there is a very good retrospective validation. So looking at this data, and of course, something new that is coming up in this ESMO 2024 is TNBC-DX. Again, by the same group of this Dr. Alexis, that TNBC-DX is going to come up. So let me ask.
Amol, can I make a comment here on this third?
Yeah, please.
So I think,
Please.
so, they, as you rightly said, in the APT trial, they applied the HER2-DX. So in the APT, as we all know, it's like, T1 and up to 3 centimeters and 0. So 20% patients were HER2-DX high risk, and they actually relapsed. So therefore, they deserve better or more aggressive treatment than APT.
Yes. So that is the question that I want to ask both my panelists, Dr. Vijay and Dr. Senthil sir, that do you think, forget about avoiding surgery, but what about de-escalation of anti-HER2 therapy based on HER2-DX score? Do you think this score, are you happy with the data? And do you think it will be utilized in future for de-escalation or escalation of anti-HER2 therapy? So Dr. Vijay, your thoughts on that?
Yeah, I do feel that HER2-DX will help us to either de-escalate or escalate therapy in the future. Like Dr. Shamagawa just said that in the APT, if we had identified that they were of a higher risk, then we would probably have given them a combination of dual anti-HER2 therapy with a full 6 months of chemotherapy rather than the abridged version. And
so will you like to wait for the prospective data? Will you like to wait for the prospective data, or because the prospective data may not come?
Yeah,
so as has been already answered by the founder that it is not going to come. So then what will you do? Will you use the based upon retrospective data, meta-analysis, or you will not use?
So I think I would be quite comfortable to escalate therapy based on retrospective data, but in a curative setting, but de-escalating would be questionable.
Senthil sir, your thoughts on this? Escalation, de-escalation based on HER2-DX on the current data, and most likely we will not get a prospective data.
If I'm not mistaken, it's already approved in Europe for use, Amol.
Yes.
Correct me if I'm wrong. I think it's already approved. So that means it's already there in the correct. So it is already there in the market, and people have started using it without waiting for any more data. So I think that's the direction that we are heading towards. Maybe we can ask for. I think I'm happy to use it. Maybe we will wait for some more real world data, but I'm quite happy to use it right away because it will avoid a lot of unnecessary anti-HER2 therapies.
So you will like to use it for both de-escalation and escalation, or only escalation? And de-escalation probably will not be
de-escalation and escalation.
Both.
Both.
Okay.
Correct.
Okay. So I think this is probably the future by 2020, where this test is already approved, and sooner or later we will get this test in India, and I think that is where the future is going. So now next question again, she asked, she's a well-read lady. So she asked, well, doc, whether ctDNA will help me to decide. So let me show you some of the ctDNA data. And ctDNA is used obviously for prognosis. And there are a lot of trials in which ctDNA is being used. There is a lot of retrospective studies. This is for Penelope B and monarchy ctDNA analysis, which Vamshi has discussed in his discussion. And they have shown that those who have ctDNA present will probably do worse as compared to those who have them absent, or probably they will, at least if it's present and it disappears, then that is what we like to see. So let me show you something which is very interesting. And the ctDNA based upon the signature assay is already approved in US, and already Medicare is covering, insurance is covering it. But ASCO says that do not endorse testing because there is no evidence either for or against it. And currently, the most approved is liquid biopsy molecular relapse. That means only in metastatic setting, not in adjuvant setting. So your thoughts, Dr. Vijay and Dr. Senthil sir, do you think in future the breast cancer will go colon or myeloma way? And do you think we'll have MRD clinics? Because already the test is covered by insurance. So in US, it will eventually come to India. People will start doing it. Then what are your thoughts? In 2028, we'll have MRD clinics? Dr. Vijay?
I think at some point in time we will, but whether it's 2028 or further up along, it's difficult to say.
Okay, so you think that the ctDNA, just like it is a buzzword in colon, will eventually become buzzword in breast also?
I think so, yes.
Senthil sir, your thoughts?
It'll become a buzzword in every cancer. Even if it is not buzzing, they will make it buzz, as you rightly shown in your slide. So I think till the time that therapies don't catch up, you will have. Okay. But what they do in those clinics is a different question altogether. So let's not discuss that. So I think the reason why it's not impacting care as much is because our therapy has not moved as quickly as the diagnostic. So when we are able to make an impact with our therapy after detecting your ctDNA or not, then that's the time we will certainly make a lot of impact by doing these tests. Till then, it's going to be strongly prognostic, poorly or not predictive at all.
So probably in future, maybe after 4 or 5 years, we'll have MRD specialist medical oncologist.
So Dr. Amal, just to put a point in here. I mean, if you rewind the clock back, say 5, 6 years ago, how comfortable were we with this concept of doing liquid biopsies? And in today's, we are very, very comfortable doing liquid biopsies. And I think as with experience and more data that comes along, I think people will become comfortable doing MRDs. But I think the question is, it just needs that lag period of time.
So let us move on quickly to the next question. And yes, sir.
Amol, I think the classical example is chronic myelogenous leukemia, where, I mean, after a particular period of time, based on the PCR report, you are able to discontinue the therapy. So I think that's the way. I think when you have, radiological CRs, so those liquid biopsies are going to be, pitching in at that time.
So let us quickly move on to the next topic, that will TDX1 take over the trastuzumab, pertuzumab? Let us not find out who is pertuzumab amongst these three. That is up to speculation. But the Destiny Breast 09 picture is that is the awaited trial in which the TDXD will be tested in first line. The data is likely to come in 2025 end or 2026 ASCO, if I'm not mistaken. So the picture is not yet out, but the trailer is out. So trailer of the movie, that is Destiny Breast 07, which is a phase 2 trial, that trailer is out. And it was presented in this ASCO. And if you see response rates, this is for the Destiny 07 response rate. And if you see TDXD, pertuzumab, it has gone as high as 88.2%. In some of the subsets, there are both recurrent de novo. And I will show you the response rates of the Cleopatra, based upon which the pertuzumab, trastuzumab, docetaxel got approval. The response rates were 80%. And here we're looking at some of the numbers going as high as 86%, 88%. And the next thing is the progression-free survival. 12 months progression-free survival for trastuzumab deruxtecan plus pertuzumab was 89%, trastuzumab monotherapy 80%. And if you see the cross-trial, all the sins of the cross-trial comparison, which we tell everybody don't do it, but we end up doing it, like all the sins, that the 12-month PFS, if you look at this curve, it's close to 75%, somewhere between 70 to 80. So clearly, the TDXD1, either alone or combination, is going to be better than the pertuzumab, trastuzumab, and chemo. So do you think this is the future algorithm? This is the thing that will happen in future, that there will be TDXD plus pertuzumab probably, or single agent TDXD, which will come up as a first line thing. And then there will be various maintenance algorithms, either tucatinib plus double anti-HER2, or palbo plus double anti-HER2 and endocrine, or maybe PIK3 inhibitors. So let me ask my panelist, do you think, first of all, Destiny 09 will be a positive trial, Dr. Vijay?
I do think it will be a positive trial. The question is the quantum of what positivity. One of the biggest problem with all these HER2 is brain protection, and we know that that TDX does provide brain protection, unlike the trastuzumab pertuzumab combination. And I think that's where the maximum benefit is going to come from. But I do feel that overall TDXD will become the first line, either single agent or in combination with pertuzumab. We'll have to wait and see.
Senthil sir, your thoughts on this? That there is at least cross-trial comparison, small sample size.
I know,
phase 2 trial
correct.
seems a lot of.
So, but I'm
So
actually not very excited looking at this trailer, Amol. Because if I was excited looking at this trailer, I would have wanted a 95% response rate. Because if you look at the Destiny 03, there the clinical benefit rate is 96%, right? And if I'm not mistaken, 86% or something was the response rate for TDXD monotherapy. Correct me if I'm wrong again. So here, for me to be really excited, I would say I want a 95% response rate when you combine the two, because you're showing a 8% difference in terms of the response rate also in your previous slide. So adding a drug as expensive as pertuzumab, as Vijay rightly pointed out, if the magnitude of benefit is not really going to be huge, then I'm going to be very hesitant. While I would love that this combination will come and it'll get better for our patients, the second problem will be it's going to have a good PFS. We have to be worried about the toxicities of these drugs when they're given over a longer period of time, both in terms of cost and in terms of the physical toxicities that you're going to incur. While we would love to see it get better, there are a lot of issues that will come up when we get to that point, starting from the magnitude of benefit to the many other things that we are discussing now. So it's not going to be as simple as what we think it is.
So of course, it is going to be tricky, especially from the cost point of view, and because it is a metastatic setting. So should we end up giving it until progression, like all the metastatic drugs that we drugs that we use in metastatic setting? So, and what after progression? So there are multiple questions.
Amol, I'll ask you one question.
Yeah.
You look into it and
please.
tell me, as you always tell, everyone should in the crossover should receive the standard of care. So now, if your TDX is given second line to everyone, and you don't have anything that is as effective as after TDXD front line, do you think that the Destiny 09 will be OS survival benefit will be there?
So it's a good question, and probably, of course, I have put that at the bottom after progression. But again, as you know, all multicentric trials, they will probably end up getting an OS benefit, saying that the post-progression therapy is compromised because the trial is multicentric, blah, blah, blah. There are a lot of things based by which the trial can still be positive. But the point that I want to discuss is that most likely the trial become positive, and then all these questions will be bombarded that can we use it forever? Because then like using TDXD until progression, because that is what we do in first-line metastatic setting. And that is where these additional trials, where probably for some duration you use TDXD, and then you step down to maybe HP or maybe HP and some other combination based upon the markers. I think that is where the future will go. Giving TDXD forever or for 1 year, 2 years is not going to happen, even though the trial becomes positive.
And a second, Dr. Sendil, in that toxicity part, because 10% will have any grade ILD, and that can happen even after a year or so. It's not that it's early event. It can happen after a long time also.
So can I just intervene here, TP? I don't think that we really need OS data to start using TDXD in first line. PFS data should be good enough because there are so many more confounding subsequent treatments that will alter OS data. So that is not second thing
Vijay, last point which I wanted, I agree what you're saying. The only point is, as Dr. Sendil's panel after that we are discussing, what is the effective therapy after a powerful ADC like TDXD?
Correct. So you cannot use other ADCs because we know that
until we get that point, it is going to be tricky. That's
so the question is that you will end up falling, because particularly if you end up using pertuzumab along with TDXD, then you really have nothing apart from some TKIs and standard chemotherapies. But if
yeah. How much time is left, Dr. Sahu? Sorry.
1 minute.
Oh, then I think probably we have to wind up. So there is a lot of exciting data coming up for TDXD in neoadjuvant setting also, and in adjuvant setting also, based upon the Destiny-05 and other trials. So last question to my panelist: how far TDXD1 will go in EBC? Do you think that it will eventually reach to the neoadjuvant therapy, or it will be Destiny-05 in which it will be TDM1, and at least for a post-NSCT residual disease it will come? And of course, this was discussed that will HER2 testing will get abolished as TDXD1 will work in HER2-0 also. So quick thoughts by Dr. Vijay and Dr. Senthil, and I think we don't have time for further slides, so we'll have to wind up here. So quick thoughts on this. How far TDXD1 will go in EBC based upon scientific evidence in the next 4 or 5 years? NSCT, post-NSCT residual?
Yeah,
Dr. Senthil?
Okay, so NSCT, difficult, post-NSCT residual, certainly yes. HER2 testing will continue to be there because the magnitude of benefit, as I mentioned, will be different. For you to quantify that benefit, you will need to do it.
Okay.
Maybe the technique might be different, but you will need to do it.
So basically, you feel that the TDM1 will probably get abolished completely, because if the TDXD is going to be there for post-residual disease, then probably there is no indication left for TDM1. Because post-TDXD progression, TDM1 anyways don't work. So that is probably is going to happen. That TDM1 probably will get abolished, even though now we have generics available. So I think we have a lot of further slides. We'll have make inroads, but probably we are running short of time.
Yeah, we will have to take it some other time.
Yeah.
So Dr. Sendil, what was your comment on NSCT, TDXD?
I said NSCT may be a little difficult, but post NSCT for the non-PCRs, it will definitely overtake TDM1.
Vijay, any last comments from you before we start?
I think by then we will get HER2 DX. By then we will get HER2 DX. That's what I'm looking for.
Or maybe a generic version of HER2 DX, like can assist
whatever
DX
it is,
or something.
Whatever it is to assist.
I do feel that Enhertu is a good drug, and it might come for neoadjuvant as well, and I'm actually looking forward to it.
Last point from my side, Dr. Sendil, Amol, and everyone, whoever is there, Sham sir, anyone. What is your role? What do you think of when you spoke of the initial slides of monitoring with a PET scan, which is tuned to look at HER2 positive, that receptor-based PET scan, like a hormone receptor-based PET scan and a HER2 receptor-based PET scan in that subset of disease? Is it going to be a part of the algorithm of follow-ups for patient in the future whom you don't want to do surgery?
No,
It is already
no,
there, and the
no,
trial has
sir.
No,
already
in
started
metastatic it
in
is there. Yeah, I hope you
No,
are getting
sir.
my question.
No, no, it will not be useful in that setting, Sahu. I think it will be useful to choose your drug in the metastatic setting.
Agreed.
Because
Okay.
so
As we spoke in
that's
best
the
of
place
time.
where we would use. Yes,
Okay.
that's correct. So
Thank you. Thank you.
So I think that's the end of it.
Yeah, thank you,
This
Amol.
we'll discuss probably next time. Thank you.
Yeah, thank you, Amol. And this slide we will keep it for some other day. And
Yes.
thank you. And I think we have come to an extensive discussion on early breast cancer and what's in the future. We will have no other than Dr. Purveshwar who will give us the take home for day one. And we started off with the maximum of 200, and till Amol ended, we are 100 odd still participants, and that is a great compliment at 9:50 in the evening. So please,
Yes.
Purveshwar, can we have you, sir?
Thank you very much. I hope I am audible.
Yes, sir.
As usual, that is the first statement when you get onto a webinar.
Yeah.
So I think Amol has really had a tough time gazing at the crystal ball, and was extending up to 2028. And I would think that there are some of the points that he took over or mentioned might go beyond that as well. So while everybody agreed that surgery is going to go away sometime in the future, I think the way that the surgery will be replaced is going to be by a method that is not really envisaged today, and that is the use of nanobots. So breast cancer is a potentially metastatic disease at presentation, and that is why the chance of relapse occurs even after 10, 15, 20 years. But what if you have nanobots that enter into the system and remove each malignant cell one by one, not only from the primary in the breast, but also from the hundreds of areas within the body where there could be a potential metastasis. So in my opinion, may not be during my lifetime, but definitely sometime surgical nanobots will be able to do that sort of treatment. And if they are very effective in doing that, then every systemic or loco-regional therapy that we are talking about will become redundant by that time. Having said that, robots are always come with a new problem. And I think the current way in which robotic surgery is being used left, right, and center across the world as well as in our country is a classic example of something being used without level 1 evidence of it improving overall survival, though there could be some evidence of it improving quality of life. But we do forget that there are more than 100 medical litigations against Da Vinci because of harm and even death among patients when they were, when there was a malfunction of the robot. So I think that is something that we need to keep in mind. The other thing that we were talking about is artificial intelligence and algorithms that allow us to better decide how to provide precision medicine to our patients. And here again, I think that it's going to be something which is totally different from what we have envisaged today. And perhaps in the next few years, we will have an AI algorithm that will allow us to anticipate what is the likes, dislikes, and the real preference of the patient. And the whole purpose would be to avoid the patient from going for a second opinion or from losing the patient while we are getting treated. Now I come back to the summarizing the specific sessions that we had today. Vamsi started with HR positive early breast cancer. And the whole discussion was Natalie versus monarchy. And very interesting that what Amish mentioned, that all, as far as ctDNA monitoring is concerned, all 46 patients who remained positive had an event. And that I think is a very profound statement. Vamsi mentioned the value of serum AMH levels to predict the ovarian reserve and whether that will help us in directing the treatment in that aspect. Lymph node positivity and lymph node negativity has been discussed at many forums, and the same thing has happened at our webinar also. And in negative high risk patients, which would be a subset for further treatment. The difference between the inclusion criteria for Natalie and Monarchy have been dissected very nicely. And this, I think, is one of the differences which will help us in deciding whether ribociclib should be used. Otherwise, the default is really abemaciclib. The session by Nitesh was also extremely interesting. And I must say that there was some discussion on oligometastasis as well as PR has happened, then how long do we continue the treatment? So as far as oligometastasis is concerned, I don't think that under any circumstances, oligometastatic HER2 positive breast cancer can be called as early breast cancer. As far as the 60-year-old female with 6 centimeter tumor and 2 disease achieved here is concerned, the discussion on the Peony trial and whether to continue pertuzumab or not was very interesting. And I think that that is something that we should expect the answer from the ongoing randomized trial that is going on in Europe. In the Catherine trial, there was a probability of 18% discontinuation of TDM1 due to toxicity. And the question that was discussed was, after that, is there a way to go back to pertuzumab or not? And whether if the patient achieves complete remission and prolonged complete remission, should we continue the treatment indefinitely or stop at the end of 1 year? And Senthil was in favor of stopping at that time. Senthil's session on HER2-low hormone receptor-positive metastatic breast cancer also brought out several important points. And the DAISY trial with a 30% response rate in HER2-0 was one that was discussed here. But in the HER2-low, we will not discuss that anymore. The bottom line was how much efficacy or response rate we can get in a patient who has had early relapse after initial therapy and has a large tumor burden with multiple sites of metastasis. And as Senthil pointed out, it is 50 or 60% response rate that is important to maintain quality of life in these circumstances. Chirag talked about early TNBC. And I think there were 2 points which most of us are in agreement with. One is that what size of the tumor, 2 centimeters or more, where neoadjuvant chemotherapy should be used. And that platinum still remains a persistent choice for these patients. So we have come down a round circle with all the sessions that have happened today. I learned a lot, and I think there are several ways in which we interpret existing data and then finally decide how to use it for the particular patient in front of me. As I always like to say, more data is always necessary, but the patient who is in front of us today cannot wait for something that we will know 2 or 3 years later. So hopefully we will utilize the discussion that happened today and be in a position to better make the right choice for our patients of breast cancer. With this, I'll stop here and hand it over back to Sau.
Thank you, sir. That was a good sum up of the whole evening. And thank you, everyone. Thank you, all the faculty. Thank you, all the attendees and everyone who participated. And tomorrow will be another day full of slides, discussions, and more importantly, we have the spotlight session of Senthil, who will be discussing the 30 minutes on how to look at subgroup analysis and how can we look at data better. So with that, have a good night, nice sleep, and we meet tomorrow at 7 p.m.